slides, make one introduction, and then we're going to get started. I have MacGyver here. He's going to fix this. We have lots of really cool doctors. We're going to introduce them to you. These are all EMS physicians. For the most part, this is what we do for a living. We're all people that rather be outside the hospital treating patients than inside the hospital. The physician response is MD1, right? It's a nonprofit organization, not associated with any one healthcare system. We'll go anywhere, 24 hours a day, 7 days a week, always somebody with blood, Reboa, transesophageal echo, everything we can imagine, 24 hours a day, 7 days a week. This is what it is. I just want you to understand this. These are physicians that are trained to be outside the hospital. Everybody in the program is a fellowship trained from somewhere. We go on up to 50 responses per week, right? So we stay really busy. And right now, we're going through the process of aligning with multiple healthcare systems throughout New Jersey, New York, Pennsylvania, and even other areas of the United States to go do field responses in that territory as well to provide the best care outside the hospital. And I'm not going to bore you with a lot of statistics, but here's what I want you to think about. There's no such thing as the golden hour. If you were taught that, you were lied to. It's not the golden hour. I'm going to tell you it's really the golden 15 minutes. That's the time when you're bleeding in the street to the time that you have to get bleeding to stop. Bleeding stops in 3 ways, right? Bleeding stops either spontaneously, if you get lucky. It stops in the operating room, which doesn't happen that much anymore, or it stops in interventional radiology. Big study that was done, which actually looked at this and said, what's the average time it takes from bleeding into the street to the time you go through the whole process of getting to the hospital, going through the ER, and then getting bleeding to stop? Roughly 2 hours and 10 minutes. You're at 15 minutes before you start to decompensate. The European model for years has been to bring people out to you who can do things like stop your bleeding. How do we stop bleeding? We stop bleeding by giving whole blood and doing several procedures to you. Because when you're entrapped in a car, you are going to die in that car if you have non-compressible truncal hemorrhage. And we're going to keep on talking about this. Our vehicles, right now we're co-branding it with about 10 other people. We're making up decals and stuff. Here's what we can do. We have 7 ultrasound machines, 4 butterfly IQs, video laryngoscopy. We keep tactical body armor, nitrous oxide field units, central line, pigtail catheters. We put in chest tubes, pigtail catheters, full chest trays, field amputations. We carry antibiotics, mostly for canine bites from the state troopers, because we provide the medical support for the state police who get bit. We have cut-down trays. We have pelvic binders, primary trauma bag, multiple types of hemostatic dressings, antibiotics, 60 medications, some really cool medications, point-of-care testing, ventilators, which a lot of medic units have. Morgan lens is not so exciting. Transesophageal echo, because we have no idea where to put our hands during cardiac arrest, right? But now we do. Reboa, junctional tourniquets, and bronchoscopy. Here's our field response units for the per month by year. And I can give you several case studies, which I'm not going to go into right now, where people actually have saved lives. We've done statistics to show we save about 41 lives per year. These are people who'd be dead outside the hospital by having us respond. And without going through this, just to save time, this is what I just said. The golden hour is a lie. It's a lie that started in 1966 and got perpetuated in the 70s. And these are all our vehicles, and we're progressing in our system. So before January, we were a for-profit organization, and then the money that we got for reimbursement for patients, we didn't even cover 1 patient. So we changed the entire model in January to be nonprofit. No system gets a bill, no patient gets a bill. We give the blood, we do everything for $0. And what happened when we started doing this is CBS called us, and Dr. Oz called us, and he said, I want to do a TV show about you guys. So I said, great. We went to LA, we sold the TV show to CBS. They got $4 million, I got $348, it's totally true. And spent 2 weeks in LA, and we proposed it to all the major stations. CBS bought the show. Greg there and Jonathan Berman or Josh Berman is very famous. They did NCIS, a lot of TV shows. We wrote the pilot, 65 pages, and I'm hoping it'll be on TV next year. This is not a reality show. This is like a drama show like ER, but they did it based upon us. And we're going to get started. If anybody wants to be on TV, just let me know. If you're not interested, we won't include you. So we have an amazing group of speakers. The first speaker, well, you know what? I'm sorry. Hold this that thought. I want to just one person, Patty Mason. Patty is the Vice President of the Emergency Department here at Newark Beth Israel Medical Center.
Hi, good evening, everybody. I just wanted to take a minute. Yeah, thank you. I'm height challenged, even with heels. I just wanted to take a few minutes to welcome you here this evening and to thank Dr. Merlin and his team for putting on this lecture series. So this is the 3rd annual New Jersey EMS Fellowship Conference. So you're in for a very informative series of lectures this evening. On behalf of Darryl Terry, who's the president and CEO of Newark Beth Israel Medical Center, just wanted to make sure that you knew how important you all are to the EMS service team here at Beth Israel and in our communities. Just so you know a little bit about where you're bringing your patients. Newark Beth Israel Medical Center has received an A grade from the Leapfrog Group for 2019. That was a big achievement for us. We were also named a top teaching hospital by the Leapfrog Group. We're one of only 53 in the entire country to receive that award. And Newsweek recently named us one of the world's best hospitals for 2019. Those of you who work in our ED and who bring patients to our ED know that we are really busy here. Last year, we saw over 95,000 patients in the emergency department. So thank you to all of you for being a part of that and making sure you're bringing the patients to the place where they're going to receive the best care. Another thing that's going on here at Newark Beth is we're going to undergo a $100 million renovation throughout the hospital. 10 million of that is going to be invested into the emergency department. We're really excited about that. Those of you who know our ED know we are very challenged with our space and our capacity issues in the emergency department here. So we will be expanding the emergency department as well as renovating and repurposing some of the existing space. So we're really looking forward to that. And those of you who know Dr. Merlin also know that we have one of the only EMS fellowships in...
We're the largest EMS fellowship in the world.
Largest EMS fellowship in the world. So that's quite a exciting thing to think that that's what's going on right here, right where you are tonight. And thank you again. I just want to say thank you very much. We don't say it to you guys enough, how we really appreciate everything that you're doing out on the streets. I used to be one of you. I won't say how long ago that was. But I remember those days, and I remember how hard it is. I also remember how fun it was. But there's a lot of things that go on now that didn't go on in the days that I did it. But thank you for everything that you do. Thank you for being a really integral part of our team. And thank you for coming tonight. Enjoy the conference.
I'll say one more thing as long as we're bringing up statistics. Recently, we were all in Dallas at a conference called the Eagles Creek, where all the medical directors for all the major cities in the world were there. The guy who runs Paris stood up and said the 2 most robust physician response programs in the world are me in Paris and Mark Merlin's program in New Jersey, MD1. So that was a big compliment, and we're now in the midst with all these great guys expanding. So let's get to the lectures. A lot of exciting stuff coming up. Zaf came in from Penn, University of Pennsylvania. He runs the ER ICU. So he's emergency medicine, pulmonary critical care, EMS. Worked in the United Kingdom as well. He's running this course, teaching this program called REBOA, and he travels internationally all over the world. And this is a pre-hospital procedure, Zaf, thanks for coming along. Thank you.
Great, thanks for coming out today. So I'm going to be talking about what I felt over the last year were a couple of really decent articles that came out in the pre-hospital literature. And Mark alluded to us moving well away now from crystalloid to resuscitate our trauma patients and using blood products to do it. We're carrying whole blood on the MD1 vehicle. But a lot of places in the hospital and a lot of pre-hospital programs are still using component therapy, and that's been the kind of the typical use right now. So there's been a lot of literature looking at whether blood itself is useful early in trauma. Has shown some positive results in that direction. But one of the other big questions was giving plasma early in the pre-hospital environment actually a useful thing? So there's two papers that came out in the last year. One with a fancy name like Combat, and the other one called Pamper, which were published just in big name journals last year. We'll talk about them. The first one was looking at aeromedical systems. This was the Pamper study out of Pittsburgh. This looked asked the specific question, does pre-hospital plasma and hemorrhagic shock actually help our patients? So it's a pretty huge trial, multi-center, randomized controlled trial, and their premise was to use either thawed plasma or standard care, whatever those programs were doing up until that point, to see which one was better. And they had fairly simple inclusion criteria, so adults who suffered major trauma, had a systolic less than 70, or vital sign reading where the systolic was less than 90 or heart rate over 108. Excluded minor trauma, cervical cord injuries, severe burns patients, people who tried to drown or hang themselves, penetrating brain injuries, and if they'd been in traumatic arrest for over 5 minutes, those were excluded as well. So the control group received either crystalloid, and they received blood only if their program was already giving blood. So they allowed that, and route to the trauma center. So these were patients who were either picked up at scene or transferred as a secondary transfer from a smaller facility to the level 1 trauma center. And the intervention group received 2 units of plasma and blood only, again, if that program carried blood, and route to the trauma center. All the other care was what they were doing in a standard fashion beforehand. So they had 501 patients, pretty sick patients, with an injury severity score meaning about 22. So anything over 15 is pretty severely injured patient. 230 in the plasma group, 271 receiving standard care. And they looked at specifically 30-day mortality. And they found that the mortality in the group that received plasma was about 23% versus 33% in the standard care group, meaning that, and this was statistically significant, meaning that their number needed to treat, so the number of patients they needed to treat to get one good outcome was only 10. So that's a pretty profound number there. So it showed significant benefit of using plasma pre-hospital. So the other group that looked out of this came out of Denver, and we have some colleagues who've flown out from there. This was the Combat trial published in the Lancet around about the same time. They both came out within weeks of each other. This looked at ground transport and whether plasma would be useful for ground transport of trauma patients. Single center randomized control trial. They used either rapidly thawed plasma, so they gave the medic units a specific warmer unit that could rapidly thaw the plasma, and versus normal saline for ground transported patients. And again, they had pretty simple inclusion criteria, very similar to in the Pamper study. And they included 125 patients in their interim analysis. These patients were a little bit sicker than the group in the Pamper study. They had 65 in the plasma group and about 60 in the saline group. And then when they looked at 28-day mortality, however, they found something slightly different. They found that the plasma group mortality was about 15% and 10% in the saline group. And they couldn't find any statistically significant difference in the two. And so they actually terminated the trial based on futility, saying that it doesn't seem to be helping our patients. So it's really interesting to look at these two trials, which were carried out in a very similar fashion, and why they had such stark differences. So a couple of different things that you're looking at. Let's look at how they were set up, where they both were looking at critically injured patients transported to a level 1 trauma center. They had pretty simple inclusion criteria in both of the trials, and they both called for early administration of plasma. But if you look at the differences, there were some unique differences in the two. So the Pamper study certainly had much longer transport times, on average over 40 minutes to transfer. These are large distances that the aircraft was flying typically either from scene or to another facility. And the transport time within the city of Denver was much shorter, often less than 20 minutes, sometimes just 10 to 12 minutes. The plasma in the Pamper trial was usually completed en route to the level 1 trauma center, whereas in the Combat trial in Denver, they often had not even completed that by the time they got into the hospital. The patients that were in the air ambulance study seemed to have much more severe injuries, often requiring going to the operating room fairly quickly, whereas almost 45% of the patients who arrived at Denver didn't actually need any further transfusion, implying that either the bleeding had stopped or they just didn't have as severe injuries. And of course, this was a multi-center trial for the PAMPER trial and a single-center study for the COMBAT trial. But I think the biggest takeaway from here is that these longer transport times really factored in. You know, these patients were well far away from definitive care, and so starting that care early in the field en route to the level 1 trauma center really helped these people, because there was no way they were going to get products any earlier, as opposed to the folk in the urban setting where they could easily get further products as soon as they got into the hospital. So to summarize, kind of pre-hospital plasma certainly seems to help, especially in more severely injured patients requiring prolonged transport. In fact, most recently, just in the last month or so, they published a subgroup analysis of the PAMPER group that actually received both blood and plasma, and seeing that group certainly did a lot better than those that got just plasma and crystalloid. So again, going towards giving all those components for transfusing these major trauma patients, and using things like whole blood just gives it more strength to that. So those were my top 2 articles from the EMS literature for the last year or so. Happy to take any questions, or we can move on to the next talk here. You want to use that?
I know I need it for broadcasting.
Okay, come on up here.
So we're going to try and just ask one question to everybody. Zeph, what a mess this is, right? I mean, here we go. I'm a paramedic outside the hospital. I got somebody who's a trauma patient with non-compressible truncal hemorrhage. They're bleeding internally. Maybe they're stuck in a car. Maybe got a long transport to the trauma center where they're still not going to get definitive care to stop bleeding very quickly. The guy's blood pressure is 60, and you want me to sit there and do nothing?
Yeah, well, it makes, I mean, if you've got those prolonged transport times, then certainly it makes sense to start these products early and get, refill the tank. But if you're only 5-10 minutes away from the trauma center, maybe the best fluid is diesel at that point.
So I have nothing to offer but crystalloid to the patient. You want me to give it or not?
Throw it out.
The guy's blood pressure is 50. They're bleeding internally. You want me to give it or do nothing?
Drive fast.
40, 30. You get it? You get it? I got 30 articles to say this. In 10 years from now, everybody will be giving whole blood. They'll catch up with us. All right, so then there are helicopter systems, and we're just looking for quick answers here, who are doing something called giving packed red blood cells. I still don't know a patient who's bleeding packed red blood cells. What do you think about this?
I think this, it's just coming full circle, right? We went from whole blood in World War II, and then it went out to component therapy, and it's only now kind of coming back into fashion. And it's, it's going to take a while for everybody to kind of pick up on that. And I think, if component therapy is all that you've got, then carry all the components to give it. So it seems like certainly this last paper showed blood and plasma together would be the best product to use. So if you're still working with component therapy, better to have both of those on board for those prolonged transports.
And there are systems in the world that are giving whole blood outside the hospital, right?
Yeah, there are. So MD1's doing it. There's groups out of Pittsburgh that are doing it, in Europe as well. And in
Harris
Europe,
County.
Yeah, Harris County as well, Cypress Creek. But there's also, outside of the US, there is freeze-dried plasma that's also available for those places that don't have the ability to thaw plasma quickly, or that's not FDA approved just yet, but that would be another option for people.
Great, thank you so much. We're going to keep moving here. And next is Dr. Hintfee. There would be no lecture that wouldn't be, there would be no conference that wouldn't be good with a little eCPR. If you don't know what this is, you're going to know in the next 10 minutes. Dr. Hintfee is the Program Director of Emergency Medicine here at Newark Beth Israel Medical Center.
Thank you, Mark. Can you guys hear me okay? All right, great. I'll just scroll through this. So I'm going to talk about eCPR. I set my timer here for 10 minutes, but I'll try to catch us up a little bit. This is kind of just an introductory thing in case you have not heard of it. So eCPR, extracorporeal CPR, also could be known as ECLS, extracorporeal cardiac life support, or ED-ECMO, extracorporeal membrane oxygenation. This has been around for decades, but it's basically cardiopulmonary bypass. And over the past 30 years, people have realized that, you know, if you put the catheters in the vessels, you could hook the patient up to cardiopulmonary bypass and generate a cardiac output of 2, 3, 4, 5 liters per minute, normal cardiac output. And that's the whole idea behind CPR. We pump on the chest and we generate a cardiac output, but it's a terrible one. And if you stop for a couple seconds, that terrible cardiac output that you generated goes down to 0, and it takes longer and longer CPR to bring it back up again. So what we're talking about here is having a team set up. It's really a whole hospital. The ICU's got to be ready to handle it. The cath lab's got to be able to handle it. If you have a STEMI, you've got to do the therapeutic hypothermia afterwards if the patient meets criteria. And you've got to have the whole system from the pre-hospital care system identifying a patient and saying, maybe we can save this person with eCPR, bringing them in with notification. So, you know, the few places that do this, they're not waiting for you to come into the resus room. They're out there with the stretcher, with the mechanical CPR device. You're coming out of the ambulance, the patient moves right over and they go. But you're basically orchestrating a team to continue with regular CPR, often led by the nurses, while some physician is going to stick some very big hoses into the patient's femoral artery and femoral vein. And this pump is going to suck the blood out of their vena cava right here, go through this machine. It's going to oxygenate the blood and take the carbon dioxide out, and then they pump it back into the iliac artery, and then it circulates. So this basically restores what is a normal cardiac output, and then it gives you some time. The patient's not dead. You might get the heart back. You say, look, it's a STEMI, or this is a big PE. We can take them to the operating room or the cath lab or interventional radiology. So this is the idea. You know, obviously, at this point in time, there are no prospective randomized clinical trials where this was proven to be better than, you know, the old-fashioned CPR. But in the limited case series that have been published, if you take the patients who are selected for eCPR, they survive at much higher rates, often 28% long-term good neurologic survival. Now, there's certainly a lot of literature about this out there. You see this one famous case in the Louvre Museum in Paris where they went out. These guys, you and Samuel were in the same sentence, so eventually we'll pass them, and we'll do this in Penn Station, Newark, on the concourse there. But, you know, they cannulate a patient and put them on ECMO in the Louvre and bring them back to the hospital. You know what happened to that patient? Multi-organ system failure and death within the next day. So it didn't really work that well. But, you know, if you take the properly selected patients, you can do well with this. And I'm just going to show you some of the things. I already had somebody brought me a patient and said, I know you guys do ECMO here, so I brought you a case in case you could save them, but we couldn't. So in general, the inclusion criteria need to be adults, not too old. Now, depending on where you are, some places will say 65 is the upper limit, some say 75. If everybody on the committee that decides this is 70, they're going to say, well, you know, maybe 75, okay. Out of hospital cardiac arrest, presumed cardiac cause, witnessed with bystander CPR. So you see these criteria start to shrink the pool a little bit as we go, but, you know, initial stoppable rhythm. So, you know, we all see patients like this. It's just not all of them. So if you take those patients still in cardiac arrest, get them to a hospital quickly, ECMO commences as fast as possible, you can see some good outcomes. Now, in general, the ECMO is a very expensive, extremely invasive procedure. If you ever see like garden hoses coming out of someone's groin and blood flowing through them, there's a lot of things that can go wrong with this procedure, an awful lot. But in general, if you're doing it on somebody who's kind of already dead, then, you know, the risk benefit is in the direction of let's do this. So you exclude people if it's not cardiac, let's say they're hanging, drowning, intracranial bleeding. There are other things, hypothermic cardiac arrest. This is one of the main indications for ECMO, VA ECMO, to heat them up. And we take out, you know, neurologic disability, dementia, bedbound, end-stage lung, liver, kidney, or heart disease. Morbid obesity makes it very hard to get the catheters in. Advanced heart failure. So all the people who at Beth Israel would get put on ECMO up in the CCU, they are not candidates for ECPR. We're trying to pick somebody who, if we return circulation, get the heart back, there's something we can fix, a PE, an MI, something that we can cure. You don't want to use this as a bridge to nowhere where you get somebody with an unfixable severe heart and lung disease. Now you've put them on ECMO. How do you shut that off with the family standing there? That's a very, very tricky thing. In other countries, they don't have the family standing there. They shut off the machine and go out and say, I'm sorry, they died. So they have different ways of doing that. Infections, obviously, that would be a contraindication. Now, I think if you're dead and you have cellulitis in your groin, just do the catheterization and you can always give antibiotics later. A couple other things, since I know I'm being followed by Dr. Colello from toxicology, but people who take a big overdose of a cardiovascular toxin like a calcium channel blocker or a beta blocker, they will be candidates for this if other measures fail. So that would be one reason, Diane, I'm going to say, send all the cardiovascular toxin overdoses to Newark Beth Israel Medical Center from all over New Jersey, and we will hook them up when the need comes. One of the things that you need to know besides those criteria would be the timing. Now, in general, if you look at this, this is elapsed duration since commencement of professional resuscitation, and this is probability of survival. Now, this is the same curve no matter what. The longer you go out from cardiac arrest, the smaller the percent of people that you are going to get back alive. Now, if you stay and play, which is currently what goes on, you're going to try to get the patient back. And if you don't get them back, you get pronounced dead. If you get the return of circulation, you rush over to the hospital. But what are we staying and playing? What are we giving? Epinephrine, amiodarone, things like that. My opinion of those things is that they don't work. I don't know if anybody else thinks that. I know some people are going to talk about it later, but you know, the next iteration of the ACLS guidelines, they're going to have to downgrade epinephrine. I mean, you know, personally, excuse my profanity, but that shit doesn't work. It doesn't do anything. And you have something here, clearly, if you restore good perfusion, you can get more patients back. So you got to make a judgment. Do you wait till 35 minutes after arrest before you say, let's go to the hospital? You know, it takes about 20 minutes in the good circumstances to get the vessels catheterized and get the patient on pump. So you've got to make, you know, based on this, they basically said they think 16 minutes after they go down, that's about the time you decide to go. But their range was like 8 to 24 based on this. And they're trying to maximize the number of neurologically intact survivors. This is a bit of a mathematical model, but you got to make some decision. You know, if you're 3 blocks away from here, you could wait a little longer to get here. But if you're down in Westfield, you can't really wait quite as long. So it's something that, you know, we're going to see a lot more about this in the future. And I think ultimately we're going to have very good coordination between the pre-hospital systems and the emergency departments in order to effectively do this. And we're taking baby steps here at Beth Israel, but it's going to be a multi-year project. And that's it. 9 minutes.
Perfect. So we're catching up here. I'm gonna save the clapping because it'll get rid of 10 minutes. And we get more education if we save the clapping. Although we always appreciate all that we get feedback. Pat, come on. I just learned I'm an EMT and paramedic. I was just told that crystalloid is bad no matter what the blood pressure is, and that's made up. I've learned for my whole life, right? And you've taught me this, that if it's trauma, load and go, and if it's medical, stay and play. And now you're telling me to load and go for patients in cardiac arrest? Because most of the time when I do that, after I work the patient for 30, 45 minutes, I get to the ER and they say, why'd you bring the patient here? It's dead. And I go, God, you have no idea what I do for a living pre-hospitally. So this is tough.
It's different, it's new, but you know, over the next few years, people are going to work this out. And I think that if you're in a market and you can do this procedure on the right patients, you know, we had somebody who came in and arrested in the ED, but with CPR, was awake with the eyes open, 1 in the morning, late at night, and basically they came in, put the guy in ECMO, and he did well and recovered. So This works better than regular CPR, but it's outrageously expensive and very resource consuming. So we got to be a little bit choosier about who we do it to.
All right, so you have to pick your patient carefully, and you have to know what hospitals around you are capable of doing EPCR.
Right.
Great, thank you very much.
Thank you.
We're going right into the next lecture. I'm going to skip people's titles, and Dr. Amandeep Tagore. A lot of titles here. Very nice.
They're made up. Good evening, everybody. Thanks for coming out. So my name's Aman. I'm going to do two articles that I kind of found personally interesting and a little bit of practice changing. So the first article I'm going to talk about is a Tripamil nasal spray. So this is basically an intranasal medication that you're going to take. It's a calcium channel blocker. And the utility of this, what we're looking at is in SVT. So patients with an actual history of recurrent SVT. So what is a Tripamil? Basically, it's a short-acting calcium channel blocker, rapid onset. And the design for this drug is really to be given intranasally only and for patients who experience recurrent SVTs. And again, the half-life is great. It's only 20 minutes. So this study that we're looking at in this article basically was a multi-center randomized double-blind placebo-controlled study, which is pretty good. They really kind of picked patients who had histories of SVT, and all these patients who had the history of SVT were actually going to undergo some type of EP study for basically ablation. So these patients are already kind of prepped and planned to have some type of procedure performed to kind of find the underlying cause of what's causing their SVT. Tons and tons of exclusion criteria. So they did pick a pretty specific subset population to kind of grab for this study itself. And I'll kind of let you guys read this. So what do they do for this randomization? So they basically did a placebo, and then they did the actual intranasal drug. But they also chose different doses of the medication. So they randomly did it against 5 different groups, and they had the placebo, and then they had 5 different doses, 35, 70, 105, and 140. And the reason how they came up with these doses was just basically 35, and they basically doubled it, tripled it, quadrupled it. And then what they did was every patient basically got 4 atomized, in each 2 in each nair, basically, and that was kind of the actual trial. So no one knew what they were getting. They were just getting 4 syringes intranasally. And some of them had basically placebo in 3, and essentially and med in 1, or the other way around. So how do we do with conversion? So what they did was they induced an SVT in a patient, and they had to induce the SVT for at least 15 minutes. So it was a sustained SVT in the patient. This was done obviously in a controlled environment. They considered it successful as far as conversion if they were able to convert the SVT into a sinus rhythm for at least 30 seconds within 15 minutes of administration. Okay. So the patients that met this kind of profile were about 104 patients that they actually were able to perform the study on. And they were able to maintain sustained SVT for greater than 5 minutes. The time at where 50% of the patients were converted basically out of the SVT into a normal sinus rhythm amongst all groups was less than 3 minutes. So, you know, if anyone did convert, they converted pretty quickly. So you knew if there was a treatment failure or if the actual intervention didn't work at all amongst most groups on average. So about 50% of patients, you know, within 3 minutes, that's a pretty good time for you to tell, okay, I'm having sustained SVT, I'm gonna take a medication, let's give it a couple minutes. Half the time I should be converted by 3 minutes, which is not bad. Adverse outcomes. So there were a couple adverse outcomes. The severe outcomes that this kind of article talked about were amongst the 3 different dose regimens. The placebo really didn't have anything. The 35 milligram one had like some facial flushing, shortness of breath, and chest discomfort. The 105, you can see nausea, vomiting, cough. And the 140 was really one that had a little bit more of a severe outcome, which was second-degree AV block with some hypotension. That happened about 5 minutes after they got converted into a sinus rhythm. It did resolve within about 20 or 30 minutes. That's pretty much it. The rest of the minor reactions were like kind of nasal discomfort, nasal congestion. A lot of this that they noticed was these reactions could have been avoided if they had raised the head up about 30 degrees and if they didn't really inhale the drug. A lot of people didn't really kind of understand the concept of intranasal kind of administration of a medication. They were kind of inhaling at the same time, and they were also may have ingested it because due to the quantity of the medication itself. No adverse outcome led to death itself, which is good, or the study being discontinued. So let's look at the conversion of SVT. Um, so statistically significant outcomes were within the etripamil 70, 105, and 140. At the 35 milligram dose was not statistically significant, and the placebo obviously was not. But 70 and above, you did see some. So for the most part, you could pretty much say that when you look at some of these graphs and stuff, it pretty much, you saw an increase in the conversion of SVT, and then it plateaued right about 70. So really, if you got 70 or 140, it really didn't make too much of a difference. And I think that if you really wanted to give this medication, probably 70 would be the ideal dose if I was considering this in my own practice. Now, what I want to bring to your attention, which is really, really cool, is the placebo. 35% of patients converted into a sinus rhythm with placebo. Like, how crazy is that? Like, I mean, if I'm not going to give any drug at all, and if I want to just convert myself, I could just spray some saline into my nose and convert myself. Like, how amazing is that? So if I really want to try something, and if, you know, and you want to do something that's, you know, especially a lot of places who don't have, you know, intranasal calcium channel blocker, this one really available, you could really just try an intranasal saline and see how that does. And 35% of the time, you'll convert into a sinus rhythm, which is pretty cool. I'm sorry? I mean, so in a sense, it would be. I mean, I think that's what's probably happening. So most patients are pretty well known, like if they're an SVT, they have a history of SVT, they'll kind of vagal themselves. If they fail, then they'll try to use something other method, or probably come into the ER. Our efforts is to kind of stop them from coming to the ER at all and just administer them just themselves at home. I think what's happening is probably they're vagaling a little bit from the actual atomization into the nares. So this conclusion of the study has really got, you know, the actual etripamil's high efficacy for rapid SVT determination and conversion into a sinus rhythm. I think this is a pretty good drug if people know that they have a history of SVT, have a reoccurrence, that they can self-administer this before having to come to an ER. And they'll save themselves a visit and going through like a whole bunch of testing, you know, for no reason. And I think that really in the inpatient stay for us in the emergency department, or even EMS, is that maybe we could try this instead of trying to get a line in, getting them on a monitor, and then trying to push some of the medication on. Instead, we could just try a placebo effect and see if that works. So I thought that was kind of a cool study. And it did change my practice. I've done it twice now. Once it worked, once it didn't. So I'm a 50-50 shoot right here. So I think it's kind of pretty cool still. My second article is about nebulized TXA for pediatric secondary post-tonsillar hemorrhage. This is a really, really cool article. I think more and more what we're doing nowadays is we're using TXA for everything. I think we're moving into a world where if I had two things on me, it'd be ketamine and TXA and whole blood, of course, Dr. Merlin. But you know, for the most part, like TXA is a great drug, and this is a nice case study that was done on a pediatric patient that had post-tonsillectomy hemorrhage, and they utilized TXA. So obviously we know that post-tonsillectomy hemorrhage does occur. It's pretty rare, but it does happen. When these patients do come in, they're pretty sick. And it's really hard to control a lot of their bleeding just because of the anatomy and where you're trying to tackle this bleed. Typically does happen about 4 to 10 days post-operatively. And the mortality is, you know, 1 out of 500,000, but, you know, it's a kid. And you know, 1 out of 500,000, we're not going to want to take that chance. So we want to be aggressive with these patients. And a lot of the management in the emergency department is really bleeding management, bleeding control. How do we stop the bleeding? And these are like eschars that have kind of popped off, or scabs that have popped off, or something flicked, and they kind of break off that granulation tissue that's kind of scarred off from the burn. And these patients bleed a lot. It's a very vascular region. And really our management is stabilization and stop the bleed. A lot of strategies have been deployed. A lot of times you get fluid. Try direct pressure, which most people try and fail. It's usually a lot of it is due to the fact that the child does not really tolerate direct pressure. That just doesn't happen, but you can try it. Clot suction, silver nitrates, pledgets, and some topical epinephrine. So this study's a 3-year-old boy, tonsillectomy, 4 days out, started coming in with hemorrhage, gurgling sound and blood emitting from the oropharynx, BP they couldn't get because the child was just thrashing around. SATs are fine, so we got some time. The initial approach was, despite suctioning lots of blood, the blood continued to come out. They kept suctioning, blood kept coming out, and they couldn't really determine where the exact bleed was coming from. They couldn't get IV access just because, again, this kid was thrashing around. You can't really control a child who's actively bleeding in front of you. The initial management was racemic epi. They gave it, administered it within like 10 minutes. They still couldn't get bleeding control to stop. They deployed TXA immediately following after that. They noticed that the bleeding was not being controlled. They used IV form of TXA, nebulized it, 250 milligrams, and gave it over about 2 to 3 minutes with a flow rate of 80 liters. So the TXA dosing, where they came from, there's not a lot of literature out there, obviously, but they used literature from diffuse alveolar hemorrhage in pediatric population. And what they really use is 250 milligrams for children under 25 kilos, and above, they use 500. Again, if you have a larger child who's kind of getting more towards the adult kind of weight, ideal weight, you'll give the full gram. And the ED course, really, approximately 5 to 7 minutes after completion of the TXA, the bleeding stopped. And then within the next 15 minutes, they got IV access, and then they took the patient to the OR for definitive management. Now, a lot of times we think about, like, does TXA, was this contaminant, and was it with the racemic epi and the TXA? We'll never know. But definitely, this is a great case study, and this is definitely practice changing for me.
Great, thank you very much. No clapping? Good, I know you. Man, so what am I learning tonight? You can stop SVT by squirting saline up somebody's nose. 75% of the time, this can't be right. And then, and this is not a Quest 35. But then I raise somebody's legs at the same time, and I squirt saline up their nose. Now I'm stopping SVT 75% of the time. Oh man, isn't this weird? And so these people, when this intranasal calcium channel blocker comes out, are going to maybe stop calling EMS.
Right.
Okay,
Right.
great. We're going to keep moving. Our next speaker is Dr. Diane Colello, who is the Executive Director, Medical Director for the New Jersey Poison Control Center, and is a pediatric emergency medicine doctor and a toxicologist. All yours, Dr. Colello.
Okay, thanks for having me. Hi, everyone. Oh, that's loud. So I am going to talk to you about two important trends in drug abuse that we're definitely seeing a lot of this year, and that I think we're going to see more and more of. But first, I have nothing to disclose other than an overarching philosophy that drugs are bad for you. And I could finish there, and then you could catch up on the agenda if you want. But all right, first things first. It's impossible to go anywhere right now and not hear about cannabis or talk about cannabis. We're in a cannabis revolution. Across the country, states are implementing medicinal marijuana, legalization of retail, recreational marijuana, and this is a topic with many, many facets. And I think there's a lot of different viewpoints out there about pluses and minuses, and I just say that everybody's got an angle one way or the other. I'm just going to talk about one very specific aspect of it tonight, which is adults with cannabis toxicity. And anytime a drug is rolled out, whether it's a pharmaceutical for cholesterol or it's a recreational drug, you're going to see some adverse effects. We'd be silly to not think that. And knowing what they might be and recognizing them as healthcare providers is our responsibility. Generally, these cases, what does cannabis toxicity look like? It's generally mild, right? People who present to the emergency department after marijuana intoxication, first of all, is the minority of patients who use marijuana. But usually they have some hallucinations, maybe even just kind of a general feeling of panic or some tachycardia, flushing. But as the dose or the amount of THC consumed increases, the severity of effects can increase. And so that can be hallucinations, even to psychosis, outright panic attacks, and in severe cases, things like seizure, agitated delirium, and in very high doses, coma and respiratory depression. So that is definitely a very small sliver of this issue, but one that we do sometimes see. So this is a study out of Denver, where so much good cannabis research comes out of. They've got a very robust state-sponsored surveillance network. And this was in a large tertiary hospital in Denver, 100,000 patients, in which they basically selected people with emergency department discharge diagnoses that were cannabis attributable in illness. And then they looked at the characteristics of those patients, compared them with who had an edible exposure and who had an inhaled cannabis exposure. And this was a period of time in which the amount of THC sold by weight in the state of Colorado quadrupled. So there's a period of a lot of growth. Not only the amount being sold greatly increased, but so did the strength. And this is happening nationwide. a joint cigarette of cannabis or marijuana now is up to 20 times more potent in terms of THC concentration. And so everybody's getting more THC than maybe they bargained for and certainly than they used to get. And edibles also do sometimes have very high concentrations and high doses, and obviously they look quite delicious. It gets a little tricky when you start to look at pharmacology. So smoked cannabis takes effect right away. You take a hit, that hits your bloodstream in a minute, and it wanes if you only take one over the course of a couple of hours. Generally, users who inhale cannabis self-titrate. They take a hit, they take another hit, and then, when they start to feel the way they want to feel, then they stop smoking until it starts to wane. Edibles don't take effect for 1 to 2 hours, and sometimes an impatient cannabis user will consume a lot of doses waiting for that first dose to take effect, and then they get hit with a big wallop. So this is a graphical depiction of that. Red is inhaled cannabis, which literally achieves a high concentration within a minute or two of inhalation, and then wanes over the course of about 4 hours. Edible cannabis doesn't have that big peak, but has a much longer effect. So this was the subject of a famous New York Times editorial by Maureen Dowd, who flew out to Denver as a cannabis tourist, bought a candy bar, ate the whole damn thing, and spent a very unpleasant, psychotic 24 hours in her hotel room. So with that background, how big of a problem are edibles? Because if you talk to people who are doing a lot of this work, a lot of them say the big headache really is edibles. So this study found that this is edibles. This is overall ED cannabis attributable visits. These are edibles. These are inhalable cannabis exposures. So you can see there's a lot more of the inhalation exposures, but edibles were disproportionately represented for the amount of edibles that are in the market. Okay, so this was up to 10% of their sample of 2,500 patients. But at the time of the study, the authors estimated that edibles only comprised about 0.3% of cannabis products being sold. So they did seem to cause more mischief in terms of ED visits. And if you look at the clinical effects, the patients with inhalation exposure were predominantly male. They were more likely to be admitted because most of these patients had cannabinoid hyperemesis syndrome. That is unique to chronic, high intensity cannabis inhaled use, and ends up getting people admitted. The edibles had a female predominance and a higher incidence of acute complaints, psychosis, panic, anxiety, more severe intoxication and cardiovascular events. So that can be things like MI and dysrhythmias, but sometimes is, chest pain and tachycardia. I will say those serious adverse events are definitely a hot button when you talk about cannabis, and they were definitely seen in both groups. So the conclusions of these authors is that the edibles led to more emergency department visits, kind of in proportion to how much they're being sold, had an increased amount of certain clinical conditions, and perhaps they just need more regulatory focus and maybe belong really in the medicinal arena alone. So I'll conclude this topic with a PSA from the state of Alaska, which I think really encapsulates this very well and is just good to keep in mind. Start low, go slow. And I think most of what gets adults in trouble is a failure to remember this. Kids are a whole other story in a different lecture. All right, and now for something completely different, diarrhea drugs killing people. We started to see a couple of years ago patients who appeared to have opioid use disorder who were dying from cardiac arrest, not respiratory arrest, not respiratory depression, not found down, but wide complex tachycardia or torsades, either pre-hospitally or in the emergency department. And the more it started to happen, that's absolutely happened here in New Jersey, it's happening nationally, the more that started to happen, the more we realized the common thread was taking high doses of loperamide. So loperamide is the active ingredient in antidiarrheal drugs like Imodium. It is a weak mu-opioid receptor at regular doses. It does nothing from an opioid standpoint if it's taken for diarrhea, but if it's taken at like 100 times that dose, it crosses the blood-brain barrier and causes opioid effects. it can cause a high, and it can lessen the symptoms of opioid withdrawal, but the toxicity of it is really more uniquely cardiac, and that occurs at doses lower than what causes respiratory depression, and of course does not respond to naloxone the way respiratory depression does. So we undertook a study using a prospective registry, the Toxic Registry. It's a national small registry of medical toxicologists seeing patients at the bedside. And so this is undertaken by the American College of Medical Toxicologists. And like I said, it's small, but I think it does provide valuable detail compared to a larger surveillance database. In the registry, in 6 years' time, there were 26 patients, and the doses ranged for anywhere from 4 milligrams, which is where you might start for diarrhea, to 400 milligrams. And patients used this for a variety of medications, but the most common was misuse and abuse, and the most common of those was to avoid withdrawal. Clinical effects that were seen were in sometimes CNS, altered mental status, but we saw a lot in this cohort, like more than half of patients with dysrhythmias and cardiac arrest. There were no deaths in this series. And it was clear that higher doses greater than 100 milligrams, had a higher incidence of acute cardiovascular events. So again, we're talking about, you might take up to 16 milligrams for diarrhea, and we're talking about 200 pills. And just a many fold overdose to achieve this effect of avoiding withdrawal. So in conclusion, in this study and also in the national data, I will say this is an increasing trend. We're definitely seeing more of this. High doses cause cardiac dysrhythmias before opioid respiratory depression. I think users may not realize this risk and may think this is yet another thing that bystander naloxone can reverse if it happens, or may think that if they just take too much, they'll fall asleep like every other opioid, and this is a precipitous cardiac risk. So I present this to you so that you are aware of the trend, and then just a very quick reminder that we're always standing by at the Poison Center, even though my phone number is blocked out by the logo. 24/7 healthcare professionals answering the phone with people like me, medical toxicologist backup for kind of multi-level specialty and subspecialty consultations. So call us anytime. Thanks for your attention.
So that is great. We're going to be quick here. Dr. Colello, I only have one question for you, and I've been waiting the whole year to ask it. You ready?
No, but go ahead.
Oh, this Narcan thing, what a freaking mess this is. When I was a paramedic, I got taught to give everybody who overdosed on heroin 2 milligrams. Then I went to medical school and did a residency, and I was told I was totally wrong. And I read a lot of papers by smart people to say I should be giving 1/10 that amount, like 0.05 milligrams of naloxone, because I don't want people to actually wake up. I just want them to get to breathe them a little bit. And now I get calls all the time. Should we give 4 milligrams, 8 milligrams, 16 milligrams? I'm waiting for the first question to give. Should I start with 100 milligrams? So you have a patient who's breathing 2 times a minute, who's a little hypoxic, who really probably is a heroin overdose, but I don't know for sure. Who knows what they took with it? What's the dose in 2019 for naloxone?
I think it depends a little on route of delivery, right? So the 0.04 milligram dose we talk about is IV. We know that's 100% bioavailable. When you're talking about flooding the patient's nostrils with intranasal Narcan over and over and over, I do think we're giving too much out in the field, and I'm not directing that at this audience, but I do feel like we're seeing very high doses coming in. And I think the optimal pre-hospital dose, again, depends a little on route, but for intranasal, I'd like to start at 2 at the highest, even though there's higher preparations and multiple doses available. And then the auto-injector is a little bit of a different story, but it's so expensive, it's hard to imagine.
One more quick
using it.
question. Somebody in this audience is thinking, but why not more? Because I've given 2 and not had people wake up,
Yeah.
and now I can give 4 or 8. So
Yep.
what's wrong with more?
It's precipitated withdrawal is a catecholamine-rich state, right? So somebody who goes into withdrawal and just through abstinence may be very uncomfortable, but is not at the risk that throwing somebody into precipitated withdrawal can really bring about. And so, and we also have to keep in mind what we're trying to accomplish. We're not trying to accomplish alertness. alertness is a real pain in the neck with a lot of these patients, right? They want to go home, and we're just trying to accomplish going from a respiratory rate of 2 to 7, or so, you know, just getting to, adequate oxygenation and what, some modicum of ventilation.
Great, thank you. We're going to go right into Dr. Hobein. She is one of our EMS fellows. She is leaving us. She came from Chicago, and she's going back to take over areas around Chicago.
Take over the entire city. Can you guys hear me okay? Excellent. Okay. That's good. Okay. So obviously you guys have picked up on the trend by now. The task we were given is to choose the 2 of the articles that have come out this year that we've discussed, particularly for us in Journal Club, that have been important to us or maybe practice changing. And ironically, the 2 that I found the most interesting and the most practice changing and helpful for me revolve around cardiac arrest. So my topic is really trying to decide if running the code is the right thing. And once you're running the code, are you giving the right medicines? So the first article that I really, really enjoyed was this one, and I practiced saying this a million times before I came here. So this revolves around the Bokuto criteria for withholding resuscitation in non-traumatic out-of-hospital cardiac arrest. So the Bokuto criteria include 3 different things. You are Bokuto positive if your age is greater than or equal to 73 years old, you had an unwitnessed arrest, and you have to have a non-shockable initial rhythm. So bystanders put on an AED, the AED did not recommend that shock, and so that puts them in this group. Even if the AED or the first set of pads that's put on the patient is by paramedics, it still has to be like a non-shockable initial rhythm. Obviously, that might not be the very, very initial rhythm that you're in, but you wouldn't know before then. So what this study did was they looked at the trial of continuous or interrupted chest compressions during CPR, that database, and they took adult non-traumatic out-of-hospital arrests, and they classified patients as either Bokuto positive or negative. And the primary outcome that they looked at was whether the patients had favorable neurologic outcome at hospital discharge, which was a modified Rankin scale less than or equal to 3. I know you all know exactly what that means, right? No, I have a slide to review that because I never remember. So, and then they also looked at the number of EMS hours and hospital days per patient with those favorable neurological outcomes. So just for reference, so you guys are aware, sorry if it's a little bit blurry, but basically their definition of a positive neurological outcome is anything that is on this side here. So moderate disability where they require some help, but they're basically able to walk without assistance. That was like their cutoff line. So any neurologic deficit worse than that was not considered a positive outcome. And what they found was they had 21% of the people they enrolled in the trial were Bokuto positive. And they found that 0.51% of these patients had favorable neurological outcome and only 1.2% survived. So the Bokuto criteria had a positive predictive value of 0.995, which is pretty darn high. And then they also found that the people who were Bokuto positive were utilizing 91 hours and 199 days of hospital time and pre-hospital EMS hours versus 5.7 hours and 38 hospital days in those who were Bokuto negative. So not only did they have low chance of positive neurological outcome, but they utilized much more resources if they were Bokuto positive, and we ran the code in full, got ROSC, and sent them to the ICU, et cetera. So basically what they determined, and what I took away from this article, is that this criteria can help us really kind of narrow down 1/5 of those out-of-hospital cardiac arrests who are really unlikely to benefit from resuscitation. For me personally, this was particularly pertinent this year. This is the first year for me doing so much online medical control. In Chicago, it's not necessarily like that where all of the medics have to call in and get permission to stop resuscitation or to do the TRE. And so for me, initially, it was a little bit scary saying, yeah, go ahead, here's, the time of death over the phone, not being able to see the patient, not being able to perform my own assessment. You guys, as residents, you guys do this every single day on the phone. I don't know if you guys were terrified at first, but I definitely was. So anyways, thinking about these criteria gives me a little bit more confidence in that online medical control situation. And also, in general, if a patient somehow makes it to the hospital here in the ED meeting these criteria, it gives me a little bit of sense of peace to be able to say, let's stop. It's been 30 minutes. They meet these criteria. They're not going to have good outcome, et cetera. So let's say you have a patient who's Bokuto negative, and you decide that it's definitely worth it to run the code. So the next question is, at what cost are we running these codes for the patients in the end? So this was the other article that I really enjoyed, which came out just August of this last year, looking at use of epinephrine in the out-of-hospital cardiac arrest. Oh, I'm actually pleasantly surprised that my slide transitions worked. That makes me happy. So this was the Paramedic 2 trial that they looked at in the UK. They had about 8,000 patients with out-of-hospital cardiac arrest who were administered either epinephrine or saline, and they all got the standard care by paramedics, so the ACLS, other than getting the placebo. They didn't know. They basically had these syringes in manila envelopes, and they didn't know which one was which. And so when it was time to give the medicine, they grabbed whatever the next manila envelope was, and they administered the medicine. So they were completely blinded to what they were giving the patients. So the primary outcome that they looked at was rate of survival at 30 days, and then the secondary outcome was rate of survival until hospital discharge with a favorable neurologic outcome, which again was the same criteria with a score of 3 or less on that Rankin scale. So what they found was that 3.2% of the patients in the epinephrine group and 2.4% in the placebo group lived. So more people survived the cardiac arrest with epi, but there was absolutely no significant difference in the proportion of patients who survived until hospital discharge with a favorable neurologic outcome. So what they are saying in a nutshell is, yes, giving epi gets more people's pulses back, but it doesn't bring more people back to their baseline neurologic state. It doesn't give them the high quality of life that many people perceive to be the ultimate benefit of recovering from a cardiac arrest. And that the bottom paragraph there is basically saying, you know, at the time of discharge, they did have more severe neurologic impairment in the survivors of the epi group than the placebo group. But that's also because there were more survivors of the epi group in general. So for me, Merlin asked me this when we presented this article in Journal Club. So why not tomorrow? Why not stop giving epi? If paramedics can call you on the radio and they say, do you want me to keep going? Should I give epinephrine? Are you going to say no? And that was a really hard question, because I think that my answer right now would be, even though this article is, it speaks to me and I think it makes sense and the data is good, I still would feel a little bit insecure about that. So I think that it's going to take a while for this to catch on. I think they're probably going to have to do further studies and publish a couple more articles before this becomes the actual trend, the gold standard, if you will, which I know Merlin hates that term, but in the end, I think that what these two articles are showing us is that we need to increase public education regarding CPR, because initiating CPR right away on scene and early AED, early shock, those are things that have been proven to improve outcome time and time again, not epinephrine. So I just threw up the name, like Illinois Heart and Rescue is just an example of something in Chicago where they're going out and educating the public about how to do CPR, so that maybe we can increase the chance that somebody's going to get CPR right away. Maybe this is going to change our TRE protocols. Maybe it's going to create more wide acceptance for the TRE across the country, not just here in Jersey. But I really enjoyed these articles, and I think that moving forward, it's going to change my practice. So
somebody spoke of positive. You're saying that once we determine they're both positive, we shouldn't even.
well, so you have to have initiated CPR in order for them to meet that criteria, because one of them is. So I don't know if there's a hard answer to that, because I think that you would have to do, I think you should still do CPR for a short period of time on anybody that you recognize is in cardiac arrest. I wouldn't recommend necessarily that a layperson decide, oh, this person's, they look over 73 and the AED told me not to shock them, and I just found them down on the street, so I'm not going to bother. You know what I mean? I think that what it means is maybe we don't continue doing CPR for 40 minutes. Maybe it's, you know, you try 2 or 3 rounds, and if you're not getting any change in rhythm, then that's the time. I don't know if there's a like solid hard answer for that.
Based upon the Bakuto criteria, I just keep wondering how I'm going to feel about the criteria when I'm 73. I don't know. It's like, hey, it's very interesting that you're saying that it's challenging for you to initially, at least, to pronounce people over the radio,
Yeah.
which is interesting because, I mean, like you're for real. You were a paramedic, you were a street person for years, and you're an EMS physician, and you're challenged. Imagine how the ER physicians are, who on average get 6 days of pre-hospital care during their entire 3 to 4 year residency. They have no idea what we do. It's just kind of interesting. So maybe this is why sometimes people get bad orders. I don't know.
Yeah, I don't know.
So epinephrine, come on.
I know. I knew you were
VFib,
gonna say
cardiac
this.
arrest, they're all poisons. Nothing works. Why are we giving epinephrine?
I think it goes back to that same mantra, which we've all said it before. I'm like, well, it's because it's what we've always done, and because no one has shown us something better. And I think this is one of the first articles that has really come out that has shown us that that they're not saying this is better, but they're not saying this is worse either. And so if you could maybe preserve neurologic function by not flooding people with epi, who knows what the outcomes might be.
And we
So,
know there's no other tachydysrhythmia that we give epinephrine for.
Right.
Right. So, okay, fantastic. We're going to jump right into Dr. Joseph. Dr. Joseph is another EMS physician who is staying on with us here with faculty.
okay. All right. I'm not Dr. Parrish, by the way. Thank you, everybody. So now for something completely different. The two articles that I'm going to talk to you today, the first one was an after-action report of the Las Vegas shooting. Just real quick show of hands. Everyone remember this? I ask because I feel like there's so many active shooting incidents today that sometimes we kind of forget these. So this event I'm discussing right now was the Route 91 Harvest Festival in Las Vegas. And for those of you who don't know what the event was, this was a country music festival that had been an annual event held for 3 years in a row. The event was 3 days long. It was called the Neon Sleepover, and approximately 22,000 people were present at the night of the shooting, including first responders as well as police and all types of different people who were there at the time. In terms of a timeline of what actually happened, at around 9:40 p.m., Jason Aldean took the stage, and during the sixth song in his set at 22:05, a lone gunman opened fire into the crowd of 22,000 people from the 32nd floor of the Mandalay Bay Resort and Casino. The gunfire lasted for about 10 whole minutes. Could you imagine 10 whole minutes? That's like Janae's entire speech that she just talked about shooting that whole time. Crazy. So that's what happened at the time. So what happened during this event? 58 people were killed. Over 850 people were injured during this gunfire. And it was considered the deadliest mass shooting by a single individual in modern history. So I thought this article was pretty important because I think us as ER physicians, EMS physicians, medics, EMTs, everybody needs to know about this, and we need to take away something from an incident that's as horrible as this one. So in terms of who responded to this event, there were 13 separate agencies, 9 of them from law enforcement, 4 fire departments, and 3 private ambulance companies. And for those of us out there in the field, we know how difficult it can be to sometimes work across different agencies. And, a lot of people came together. So this is pretty fantastic. This is just a list of all types of different agencies. Obviously, we don't need to read every single one, but everyone from communications, 911 operators, dispatchers, law enforcement, fire, EMS, were all involved in this event. The report itself was pretty extensive and actually made 72 different recommendations on how we can improve our responses to active shooter and mass casualty incident. I'm not going to go through every single one today. That would be crazy. And I don't have can't do that in 10 minutes, but I can give you the top 5 incidents top 5 recommendations that I think are important for us to know. So the first recommendation that they talked about, which I think is important for those of us who do standbys with event medicine, is to keep a supply of these things called MCI throw kits. So what's inside a throw kit is pretty basic. It's a sealed plastic bag. You can make your own with a Ziploc bag. Throw a pair of gloves in it, throw a tourniquet in it, just the same tourniquet that you would use to start an IV, some tape, maybe a gauze pad, and keep these in mass. And if an event like this were ever to occur, police or even security guards can throw these out into a crowd and tell people to stop their own bleeding or help the people next to them. That's what they found in a lot of these events. You know, people aren't really trained necessarily to stop the bleeding, and you know, we're working on that as, you know, culturally, but people figure it out. They put their hands on the bleeding stuff, and, you know, sometimes people would be more likely to do that if they had a pair of gloves. The second recommendation that they made is to get certified in how to actually speak the language that is getting spoken all around you. So in terms of what we're talking about here is ICS, 100, 200, and NIMS. We as EMS fellows all get certified in this. I feel like every ER physician, every EMT, every paramedic should have at least this training if you don't already. And it's totally free, which is great. So I threw up the websites there if anyone wants to take a look. The third recommendation they made that I thought was important was to conduct joint training exercises with your ED. I know we do this here at Newark Beth Israel, and we've done it in my residency in Morristown. And I think it's super important because you're the people who need to be recognized and need to know what to do. And these drills are what actually allowed Las Vegas to work out the kinks in advance. They had a system called MACTAC where they all got together, tested things, found their shortcomings, and then when the big event happened, things actually ran pretty smoothly. The fourth recommendation they made is to establish a public information officer, and I like this recommendation because of that little Twitter thing there. You know, most people have some access to some sort of social media, whether it's Facebook or Instagram, Twitter, something like that. So having the hospital or, you know, the area or the township have the ability to communicate with the public and say, hey, this is happening, stay away. That's great. If anyone else has ever walked around in Las Vegas, you know how crowded those streets can get, and who knows how many lives they save that day by telling people just to avoid that area of the strip. And then finally, the last recommendation that they made that I thought was super important is to establish a hospital point of contact with your local emergency department. Whether this is your ED director or someone who is in the hospital often, you want someone who has a direct line to the police, a cell phone number, to keep them up to date with things, and you want to be able to have communication in both directions in order to make it successful. And that was the top 5 things that I found from that study. And in general, follow the 7 Ps. I know we can say this in different kinds of language, but proper planning prevents particularly poor performance. So I'm going to move on now to a completely different study. I think this is a very important study that was done this year about out-of-hospital cardiac arrest in pregnant patients, because personally it's my worst fear as an ER doctor and as an EMS physician is to come upon a pregnant woman in cardiac arrest. So the problem is that this is a rare event that a lot of us don't get to experience in our training, no matter what our level of training is. But it's important because these patients are different than your average cardiac arrest patient because you have 2 patients instead of 1, amongst many other things. So this study took place in the beautiful city of Paris, France. And their system, believe it or not, isn't that different from ours. They have a 2-tiered EMS system, ours meaning the state of New Jersey. They have a 2-tiered EMS system where they send BLS teams to the scene, and then, which is like a first responder, EMT kind of situation. And then they have an advanced team, which is a little different than ours. Instead of 2 paramedics, usually it's a paramedic, a nurse, and a physician, or some combination of 2 out of the 3. What's pretty cool about the city of Paris is there's only a 10-minute response time on average to get a physician and a nurse and an advanced care provider to the scene, which probably has something to do with why they were able to get ECMO in the Louvre, kind of like Dr. Hempy showed you before. The incidence of out-of-hospital cardiac arrest there is 55 out of 100,000 patients, and maternal cardiac arrest is 3 out of 100,000 patients. And when I looked this up, it was somewhat similar to the US. Actually, a little less, which was surprising. So what they did here is a retrospective chart review that they studied over 5 years. They had approximately, and they looked at all different types of variables. So they wanted to see how old were these women, how far along were these women, and then look at different variables in response to their system, shocks given by an AED, and then the most important question is how did these women do who were in cardiac arrest? So we'll go over that. So out of all the 16 women who were in the study, 100% of them actually were receiving prenatal care at the time. They were all seen well by physicians, were on vitamins, had gotten ultrasounds, confirmed live IUPs, a little bit different than our population here in Newark. And out of 5 years, and looking at out-of-hospital cardiac arrest, there were approximately 20,000 cases of cardiac arrest, and it was 16 women that they found. So these women had a median age of 31 years old, and their median gestational age were 20 weeks. The youngest was 6 weeks, all the way up to full term. So the most important question I'm sure everyone wants to know is how did we do? And out of 16 cases, only 2 of these women survived to out of hospital 30 days mortality. And out of those 2 women, only 1 woman survived to carry her pregnancy to term. So it's pretty staggering numbers, I thought when I read that, so I thought that was important. So in terms of, should have been up there, sorry about that. So in terms of causes of these cardiac arrests, most of them were medical. These were all determined upon autopsy or using scans such as CTAs to look for pulmonary embolism, stuff like that. Mostly medical. 4 of them were traumatic. 1 woman actually fell out of a 3-story window. 3 of them had autopsies and no cause was ever determined. It was inconclusive. And then 2 cases were either not reported or did not have an autopsy. And the question then in terms of who got defibrillated, 3 of these women received defibrillation in the field for a shockable rhythm. Only 1 of these women received thrombolysis for a possible PE. And then sure the question that you want to know is how many of these women made it to the hospital, and only, it looks like 6 women were pronounced on scene, 10 were brought to the hospital. And then the next question is how many of them actually got that dreaded perimortem C-section that we hear about and, you know, dread doing as ER doctors. So how many do you think, if you guys had to guess, out of those 10 women? I heard 1, I heard 5. So the answer is 3. Only 3 out of those women. 6 of them had already been pronounced on scene without perimortem C-sections. 10 sent to the hospital, 3 got perimortem C-sections. If you had to guess, well, first of all, EM residents, what is the magic number that they tell us? When do we do this? How many minutes after CPR? 5. So 1 woman took 55 minutes to get her C-section. A second woman was 90 minutes. Third woman was 120 minutes. And our magic number, like I said, is 5. None of those women survived. So the conclusions that we drew through this study is that this is a rare event that we're characterizing for the first time. Current recommendations for this perimortem C-section for within 5 minutes are difficult to apply in the out-of-hospital environment as well as the in-hospital environment. And I think, and the authors of the study believe, that specific recommendations need to be reevaluated and made for out-of-hospital cardiac arrest for the pregnant patient. Some limitations of the study is they didn't mention whether the left lateral decubitus position was done versus supine. Uterine displacement was not mentioned either at the time of the study. And there were some missing data values, but they did report them all. So what can we take away? 1/3 of these women who were full term with a viable pregnancy at the time of their arrest were pronounced on scene without a perimortem C-section. And the ones who did get perimortem C-sections, those were severely delayed. Should a system be in place to request a physician on scene at the time of a 911 dispatch once we know that we have a patient who's pregnant who could benefit from this? And could a C-section in the field have given mom or the fetus a chance to survive? That's it. I'm gonna think about.
Jocelyn, what is going on in Paris?
I don't know, it's a crazy place.
I mean, they have an advanced EMS system. They do all these cool things. 90, 120 minutes to a perimortem C-section when that's the only thing that really works. Now, I've done one perimortem C-section in my career, a full-term woman who coded, and mom died. Mom was asystole and the baby lived. And I took the baby out, and then, you know, luckily I had a million people to hand the baby to. And then, you know, OBGYN came down, just sutured the mom closed. Somebody else did the airway and a few other things. You know, this is what makes people survive. Why were they not doing perimortem C-sections?
I don't know. I would think that if their median time to the scene was 10 minutes, that this is a viable option in this location.
I mean, even if we were called for these patients, the truth is we would probably just never get there, right? Because they would probably be too far away from wherever we happen to be at that moment. If they're a long ways away from the hospital, which could happen some places, we might be able to intercept them, and we have the equipment, we could do it. But, you know, odds are of that happening and us being able to intercept are very, very unlikely.
Right. I think the thing that bothered me the most was the fact that these women got pronounced without getting this done.
Yeah.
So.
Yeah. Right. Well, one is the hospital going to do it. I hope they are, but I don't know for sure. And two, right. You know, and two, you know, yeah, I mean, I think, you know, quick transport, move the patient quickly, and, you know, hope they're going to do a C-section and they're prepared. You know, I would go to the closest hospital because doesn't matter if you have OB or not, the ER doc should be able to do it. At least they learned it when they were an ER resident. You know, and, you know, this is a much easier procedure than doing a regular C-section. This is totally the opposite. It's just that we don't do it that much, right? So it's very rare, and so we don't have a skill set that makes us comfortable. But I think most people are prepared to do it. Yeah, I would drive really, really fast, and I don't say that too much. Okay, we're going to move right into Dr. David Ben-Eli. Dr. Ben-Eli is Medical Director for the Hazardous Material Unit for the Fire Department of New York in New York City and an EMS physician.
Okay. So that's advances. Thank you very much. I'm one of the division medical directors at the New York City Fire Department. I'm very glad to be back here again. I couldn't make it last year because I was talking at a different Medivac conference. So I'm glad to come back this year. And I'm going to continue quoting Dr. Joseph, and now we're going to talk about something completely different. I also apologize because on your agenda it says that I'm going to talk about stroke. Although I'm glad to talk about stroke, it's been sucking up a large portion of my life for the past 3.5 years, 4 years. We will talk about something different, and it's going to be in-flight medical emergencies. I'm going to quote 2 articles. The first article was just published in JAMA in the end of December, so it's really just a recent article, and it's a review article, and it stems off from a previous article that the same group published in New England Journal of Medicine from 2013, I believe. It's not surprising. This is a group from Pittsburgh. They have a large ground-based medical control that provides medical control to flights of 5 international airlines. So they have one of the largest databases to date about in-flight medical emergencies. Why are we going to talk about this? For the simple reason that most of us healthcare professionals are going to receive this notice overhead, or now more recently on your screens in front of you. If there's a medical professional on board, please identify yourself. Just let's do a raise of hands over here. How many of you have actually taken care of people in flights? Okay, so not an insignificant number, right? So we all are going to be called to do this, and let's talk a little bit about it. And this becomes especially important because with the increase of life life expectancy, we see more and more people that are flying with pre-existing medical conditions. It's very hard to actually try to identify the amount of in-flight medical emergencies because the FAA does not mandate tracking of in-flight medical episodes. Airlines are not required to record them either. So what these authors from Pittsburgh did, they did a Medline pub search. These are the criteria: English-only articles, and for a large period of time, from 1990 to mid-2018, they used terms of air emergency, air emergencies, air passenger, air travel, fitness to travel, airline, aviation, etc., aircraft. They found almost 15,000 articles. They narrowed that down to 765, and in the end, they reviewed 317. The epidemiology, there are about 4 billion commercial airline passengers that travel worldwide annually. And this comes from their original article from 2013. The prevalence is one in-flight medical emergency in 604 flights. This is likely a underrepresentation. The estimates are that there are about 24 to 130 in-flight medical emergencies per 1 million passengers. And it's possible that this number is actually up to 260 to 1,420 in-flight medical emergencies daily. So anywhere between 260 to almost 1,500 medical emergencies daily worldwide. The most common in-flight medical emergencies are not what we think. Okay, they're syncope, near syncope, GI complaints, diarrhea, vomiting, abdominal pain, respiratory complaints, shortness of breath, and cardiovascular complaints. You know, starting from chest pain, palpitations, up to cardiac arrest. It is estimated that about, and again, this is from their analysis of a number of articles, that 4.4% of in-flight medical emergencies will result in the very airline-dreaded diversion, and we'll talk about that later. Just a little bit about pathophysiology, and we can talk about this for 2 hours. The cruising altitude of commercial airlines, it's anywhere between 30 to 40,000 feet. Some smaller aircraft can get up to 45,000 feet. And the passenger cabin inherently is never pressurized to ground level, even though there are specialized aircrafts that can do that. And it is pressurized to an altitude that's equivalent to about anywhere between 5,000 to 8,000 feet, usually 6,000 to 8,000 feet. What we need to know is, as healthcare providers, is that at 8,000 feet, the volume of gas increases at about 30% from the sea level, and that causes a problem with expansion of gas-containing spaces, closed gas-containing spaces in the body. So people with sinus problems may experience pain. You need to think about people with pneumothoraces, even though they might be, non-discoverable or non-significant at sea level, at altitude that, 30% greater can become symptomatic. Also, we have to remember that although the percentage of oxygen that we're breathing in the cabin at any altitude is always the same, it's about 20% oxygen, the partial pressure of oxygen decreases. So even healthy young adults have a pulse ox that is, they suffer a little bit hypoxia. Their pulse ox is anywhere between 93 to 97%. And this is where it becomes tricky. Patients that have baseline hypoxia, pulmonary patients, cardiac patients, they will become symptomatic much earlier. They probably will benefit from O2. Venous thromboembolism, development of PE, DVTs, the prolonged sitting associated with hypoxia leads to a decrease in the venous blood flow, and that can, and up to 10% of patients may experience DVT or PE in prolonged flights that's greater than 4 hours. Mostly remain asymptomatic, but their presentation can be within hours or up to days post the flight. Dehydration is also an issue. You have to remember that the cabin air is filtered and circled, and that results in a relative humidity of 10 to 20%. Air recycling itself can be problematic with regard to allergies, and there's a lot of discussion about communicable disease. Again, we can talk about this a lot. So you get called to a medical emergency. What can you expect to find in your kit? So to the left is the list that's required by the FAA, and then there's this is the content of the enhanced FAA medical kit. So there's quite a lot of stuff in there. You have Benadryl, you have albuterol, you have some cardiac meds, CPR meds, you can tube, you can measure blood pressure, you can give aspirin. But it really varies a lot from airline to airline, and even within airlines, you can get, if they lease the plane, they don't own the plane, you might get a really crappy kit, a really basic kit. So it really varies. So it's somewhat of an unknown when you ask for that doctor's kit, for that medical kit, as to what you're actually going to find there. So ground-based medical support is something that is available to most large commercial airlines nowadays. So when you respond to a medical emergency, in-flight medical emergency, you or the pilot will probably communicate at some point with this ground-based medical support. When an in-flight medical emergency occurs, the flight attendant notifies the pilot. The pilot establishes communication, obviously, with the airline's operations center, and then with the ground-based medical support center, which is usually a third-party operator like these guys from Pittsburgh. The flight attendant relays the information to and from the ground-based support, either via the pilot or through headsets in the cabin. Clearly, this causes communication concerns. There is no study to date that shows that these ground-based medical support changes patient outcomes or impacts patient outcomes. It's really used to try to take care of these patients and try to avoid, if possible, diversion. Again, we'll talk about this later. Let's talk about us, the medical volunteer. So when you hear, is there a medical professional on board that can assist with taking care of a patient, in the USA, you're not required to volunteer. It may be mandated in other countries. So you may be mandated in other countries outside of the USA. You're usually not required to show proof of your qualifications. So you're not required to show proof of license or certification. Nonetheless, you should never exceed your scope of practice. You should really think twice if you're going to respond if you're under the influence of either medication, you took something to calm yourself down, or you drank alcohol, or you do, God forbid, doing drugs. It's going to be a collaborative effort between you, the flight crew, the ground-based medical support. Ultimately, it's the captain's decision. The captain is the commander of the flight, and he will make the final decision of whether we'll divert or not. All this gets a little more complicated when you think about the legal and ethical considerations for medical volunteers. In the USA, we have the Federal Aviation Medical Assistance Act, which is also called the Good Samaritan Shield. It protects passengers who provide medical assistance from liability except for gross negligence or willful misconduct. We all know that when we do have a medical malpractice case and we're medical professionals, they will all try to establish that we did gross negligence or willful misconduct. So you've got to take that with a grain of salt, this Good Samaritan Shield. Also, you must remember that medical volunteers who seek compensation in return for providing aid, money, seat upgrade, mileage points, vouchers, etc., may jeopardize their standing under the existing immunity laws. Okay, so if you get some gratitude from the flight attendant for providing care, you might have now established a contract of providing service for goods, and the Good Samaritan law doesn't apply anymore. Again, to date, there are no case laws related to this that exist. Outside of the USA, it's a complex combination of public and international laws, the Warsaw Convention, the Montreal Convention, the Tokyo Convention, and the duty to respond can vary by country. So the United States, Canada, England, Singapore, there's no legal duty for off-duty medical professionals to assist. Australia and many European countries require physicians to render assistance. Nonetheless, physicians, and medical providers in general feel obligated and an ethical duty to act. There's only one USA case of a physician that's been sued for assistance, and this was thrown out of court by a judgment summary, and they didn't even reach hearing. In all honesty, there's little personal or legal risk, if that is, and to do this, and it is obviously strongly supported by aviation medicine. Diversion is the greatest fear of an airline company. It's defined as changing in the landing destination because of an in-flight medical emergency. There are multiple considerations that who we as healthcare professionals may not be aware of. For instance, an aircraft takes off with way too much fuel for it to land safely. So you either need to burn that fuel by just going around an airport, or to dump it. The newer airlines, the newer aircrafts don't have the option to dump it. And also you got to think where you are. I mean, if you're flying above the Pacific or above the Atlantic Ocean, where's your closest airport? And if that closest airport is on a little small island, will they have the medical facilities that will actually change the outcome of your patient? So all these are considerations that you need to think about. And on top of everything else, some patients who are stable enough to express their will might say, I prefer to continue to my destination. And we also have to remember that upon landing, again, from review of all these articles, only a third agreed to be transported by EMS, and only a third of those that were agreed to be transported by EMS were actually admitted to the hospital. The direct cost of diversion is very heavy for airlines. It can be up to $725,000. You can imagine that an Airbus 380 with 520 passengers, now you have to go and find hotels for all these passengers. It can be very costly. The most frequent reasons for diversions, obviously cardiac arrest, obstetric emergencies, cardiac symptoms, and suspected stroke. The article then goes on, and I recommend that you go through this. They have all these cards over here. I'm not going to go through it, where they describe common medical conditions and how to, the initial assessment and how to manage those suspected cases. So kind of cool that they created this. They even provide a list of differential diagnosis for the most common in-flight medical emergencies. Kind of cool. Clearly, prevention is the best medicine for in-flight medical emergencies. Okay, make sure that you're well hydrated. Patients with chronic medical conditions should talk to their doctor beforehand and receive medical clearance to travel. I can tell you, flying through MD1, I took care of a patient who did not meet the medical clearance. And that had its implications. Preparation for travel for these types of patients is really important. If you have an O2 generator, it has to be medically cleared to go on the aircraft. You have a glucometer, by the way, is not part of the FAA kit. So diabetic patients should bring their glucometers, should bring their medications. You must have, if you're going on a long flight, you have to make sure that you have enough batteries to support these devices. There is something called a hypoxic challenge, where you give these patients, instead of breathing 20% oxygen, you give them 15% oxygen with nitrogen and see how they respond to that. Not very commonly used. There's a YouTube video over here. For the interest of time, I'm going to skip it because it kind of reviews what we already discussed. The last thing that I want to mention is this cool app that's available both for Android and iOS. I have no vested financial interest in this app, but it kind of helps. It has a list of 23 diagnoses. It's designed by a group of residents who decided to create this app and to help with assisting with in-flight medical emergencies. So there are diagnoses, there are a list of medications. There's even an option to document, to chart your encounter with the patient for future use. That's just about it. Thank you.
Thank you. Just for the sake of time, we're going to move right into the next one. Thank you so much for coming, David. Dr. Brett Greenfield is essentially the medical director for Atlantic City. He's the medical director for Atlantic Care, Mid-Event, how do I say the helicopter? Mid-Atlantic Medical.
All right, thanks, Mark. I appreciate it. Thanks for coming out, everybody. Let's just get started. I do have one disclosure. I'm the medical director for Pulmodine and Engineered Medical Systems out in Indianapolis. It's a medical device company. I am obligated by the state of New Jersey to disclose that and will not talk about anything that I do with them. So I'm going to talk about two things. First is the COAC trial, coronary angiography after cardiac arrest without STEMI. New England Journal of Medicine, March 19th. I think we all take care of these patients on a regular basis. The ultimate question is, at 3 o'clock in the morning, after your interventionalist has cathed your 4 previous STEMIs, now you have a post-cardiac arrest with no STEMI, is to cath or not to cath. That is the question. So this is a trial out in the Netherlands, multi-centered RCT with 2 arms. There was an immediate arm and delayed arm. The immediate arm was cathed within 2 hours. The delayed arm, about 5 days was the average time till cath. 552 patients, all greater than 18, out of hospital cardiac arrest with the initial rhythm VFET. So these were clean cases. Unconscious after ROSC, and pretty impressive that 90% of patients were treated with TTM in a fairly rapid fashion. And again, no STEMI on EKG. So here's the primary outcome, 90-day mortality. If you look at both arms, patients who were alive, really there was no statistical difference. All the secondary outcomes, 90-day survivability with good neurologic outcome, number of ICU days, number of ventilator days, number of days on renal replacement therapy, no difference. Some interesting stuff here. Coronary angiography, 97% in the immediate arm, 64 or 65% in the delayed arm. This is pretty interesting because in previous studies, systemic reviews, we know that 70% of patients with STEMI, post-cardiac arrest, they have a cath-amenable lesion. Interesting enough, in that systemic review, over 30% of patients with non-STEMI post-cardiac arrest had a cath-amenable lesion. This is an interesting cohort here because PCI was only performed on a cath-amenable lesion in their immediate group with STEMI 33% of the time. In the delayed arm, 24%. So I don't know what type of patients in the Netherlands are having cardiac arrest. They don't have unstable plaque. So the big question for me is what's going on in the Netherlands? From an EMS standpoint, the median time to BLS is 2 minutes. So that's an impressive statistic, even though it's a small country. 2 minutes to BLS, which is clearly the most important metric when you're talking about if you're going to get ROSC for cardiac arrest is immediate BLS. Median time to ROSC, again, 15 minutes for most of the ALS groups. Here especially, I cover a geographic area of almost 1,200 square miles in 2 counties. That's a tough metric for me to even get my ALS folks to. Currently, the American Academy of Cardiology has an algorithm for who to take and who not to take. Clearly, it's pretty simple. Cardiac arrest with STEMI, you're going to the cath lab. Cardiac arrest with no STEMI, it really, really depends. It depends on your system. In South Jersey, cardiovascular and cerebrovascular disease is a contagious phenomenon, right? You can't believe how many patients that we take to the cath lab on an annual basis. We're the only level 1 PCI center with cardiothoracic backup in about 4 or 5 counties. We are the busiest 24/7 PCI STEMI lab in the state year over year. So we cover a lot of geography, and my cath team typically does not want to take these patients right away. So I think you need to understand what your patient population looks like. I don't know if this Netherlands study, which I know my cardiovascular guys are going to say, I'm not taking patients to the cath lab without STEMI post-ROSC. They're just not going to do it. I think the caveat here is right patient, right place, first time, every time. With the introduction of ECLS, I think the whole paradigm of where we go with our patients is going to change, as Dr. Hinchy talked about. I'm going to transition pretty quickly because I want to catch up. I know we're a little bit behind. In a topic on EMS wellness, death by suicide, the EMS profession compared to the general public. It was published in Pre-Hospital Care in 2018. For those of you who don't know, it's Mental Health Awareness Month. And ultimately the question for me is, what about us? What about the folks that on a daily basis are seeing things and doing things that nobody ordinarily should do? Dr. Joseph talked about the Las Vegas event. Every day there's another mass shooting. You don't recover from those things. Each of us on a daily basis sees things and we just kind of file them and we don't talk about it. So this study was retrospective in analysis. It was all deaths over a 7-year period in Arizona, stratified by occupation. And for EMS providers, it was broken down EMTs, paramedics, firefighters, and flight nurses. And by no means does this categorize the importance of each of those providers. Please, I don't want anybody to mistake that. And here's some of their findings. The adjusted odds of suicide as a cause of death among EMS providers was 39% greater than the general population. That is a sobering, bothersome statistic for anybody. So ultimately, when you talk about things, we always ask this question, right? You had a bad call, you had a bad shift, you had a bad case. We say this to each other all the time. Are you okay? The bottom line is, after an event, whether it's a difficult case, you're not okay. And we have to start taking care of each other like we do our patients. I think it's sobering to see some of the statistics about physician suicide, first responder suicide. So although it's a sobering article, it should be eye-opening for us to, really have each other's back. And if you see something, say something. You never know, you may save the life of one of your own, or even maybe yourself. National Suicide Prevention Lifeline, the Code Green campaign, has awesome resources for first responders and physicians. And then, obviously, next week or the week after is EMS week. Beyond the Call, that should be pretty profound in its meaning to all of us with what we do on a daily basis. And with that, I will finish up.
Brett, that was fantastic. I mean, the coax study, geez, so if somebody's a cardiac arrest with a ROSC and they don't have a STEMI on the EKG, that study wasn't a perfect study. It was pretty good, pretty well done, though. It was the New England Journal of Medicine, pretty nice statistics. We spent hours in Journal Club talking about that. Previous to that, though, we felt completely the opposite. There was a study where it was a meta-analysis of 8 studies. 7 were retrospective, 1 was a prospective randomized controlled trial, which showed there was a clear benefit. And, about 35%, there's about a 35% chance that, I want to get this out right. So there's a 35% chance that you will have a culprit lesion causing your cardiac arrest if you have ROSC with no STEMI on your EKG.
Right.
Based upon that, I wonder if we can go to the cath lab.
I will not disagree with you. Unfortunately, our cardiology colleagues, they don't want to do it. I have this argument all the time.
If 35% of people have a culprit lesion without a STEMI on the EKG, I don't know. If I was an interventional cardiologist, I might say if I'm cathing 300 days a year, it's probably challenging to come into the hospital 24 hours a day, 7 days a week. But if I'm in a place where there's lots of interventional cardiologists and we share the call schedule, it's not so challenging. This paper, the COAX study, kind of said to people, we don't need to worry about coming in so much. And that's my concern.
So that is my concern also, right? Because again, you need to know your patient population. Like I said, cardiovascular disease in South Jersey is a communicable disease. You can't imagine how many people are having STEMIs or have heart disease. And always my question to the interventionalist is, hey, you took the 55-year-old guy who's got normal enzymes, EKG looks okay, but he continues to have chest pain, you go cath him electively. Here are some of the sickest patients. And I'm not talking about, the patients who have advanced renal disease or have other mitigating factors. But the 55-year-old who clearly had chest pain and collapsed, post-cardiac arrest, his GCS is 3, he's unresponsive, he had a VT arrest or a VF arrest, take that patient to the lab, fix their heart. Don't worry about their brains. We'll worry about their brains. Zaf and his colleagues in the critical care units will fix their brains. Fix their heart. And I think, can you apply the Netherlands literature to us? I don't really know.
I mean, last question is, so should paramedics be calling pre-hospital STEMIs on cardiac arrest with ROSC that do not have STEMIs on EKG?
So no, and I can tell you from what I do in my shop, we will move those patients to the STEMI center. So even if the interventional cardiologist does not want to go right away, and I talk to them about every one of these cases, at least they're at the right place. So if something changes, and that EKG does change over time, or the patient becomes cardiovascularly unstable, they're already at the PCI center and they can go. Now, I can do that because I'm the only level 1 PCI center in South Jersey. It may be difficult to figure that out up here when there's a PCI center every couple of miles or every couple of blocks. So again, you're partnering with your colleagues for the safety and benefit of your patients.
Great, thank you so much. We're going to move right into Snao. We borrowed Snao from Japan. Snao is a flight physician in Japan. So he was doing really cool things before he came here. And he is doing his training for 1 year as an EMS physician and then going back to rule Japan.
Hopefully, yes. Thank you so much for the introduction, Dr. Marlene. So I'm going to go right into this articles. So the first one I'm going to talk about is advanced airway intervention for pediatric cardiac arrest. So this is an article from the resuscitation that looked into see if advanced airway management, such as tracheal intubation or supraglottic airway, improves outcomes in pediatric cardiac arrest when compared to the VVM ventilation and to each other. So as this is a systematic review and meta-analysis, authors performed literature search and for the clinical trials and observational studies. And for outcome measures, they defined these critically important outcomes as which are survival to hospital discharge and survival with good neurological outcomes. So after the database search and text review, they identified 14 studies that met their inclusion criteria, and that is out of 2,817 unique articles. And then they found one pseudo-randomized control clinical trial, and then 3 of them were observational cohort studies, and 8 were simple cohort studies, which was suitable for the meta-analysis. Of those 14 studies, 2 of them were not suitable for meta-analysis. So in terms of the meta-analysis, they used 12 studies for the analysis. And the majority of studies involved out-of-hospital cardiac arrest, and with few studies including the in-hospital cardiac arrest. So first, let's take a look at the comparison between VVM ventilation compared to the tracheal intubation. So for survival with good neurological function, one pseudo-randomized trial involving the out-of-hospital cardiac arrest showed no statistical difference. And then 3 propensity adjusted cohort studies showed reduced survival with tracheal intubation group. And then in terms of the survival to hospital discharge, a pseudo-randomized trial did not show superiority of the intubation when compared with VVM ventilation. And then the same 3 propensity adjusted cohort studies support harm with intubation compared to the VVM ventilation. So overall, when compared VVM ventilation with tracheal intubation, intubation-based resuscitation is not superior to VVM ventilation-based resuscitation for the critically important outcomes. However, the evidence level of the certainty of the level of this study is really low to very low. And then next, when they compared VVM ventilation to the supraglottic airway, 2 propensity adjusted cohort studies found no association between supraglottic airway placement and survival with good neurological outcomes. And then the same studies showed basically the divergent conclusions, which is like conflicting conclusions for the outcomes of the survival to hospital discharge. And then again, so overall data, although this, again, the evidence level or the certainty of this level is very low to low, there was no treatment effect associated with supraglottic airway ventilation when compared with the VVM ventilation associated cardiac resuscitation in terms of the clinically important resuscitation. And then finally, lastly, when the supraglottic airway is compared to tracheal intubation, there are 2 propensities adjusted cohort studies which showed no association between them in likelihood of survival with good neurological outcome. And the same studies found no statistical association between the choice of the advanced airway technique and survival to hospital discharge. So bottom line is, so it doesn't matter if you use a supraglottic airway or tracheal intubation. So, like I said, the level of the evidence or the certainty of the meta-analysis was very low to low. So we definitely need more further trials to see if the findings consistent with the other studies. But at this moment, conclusion is that resuscitation with advanced airway technique, either tracheal intubation or the supraglottic airway, are not superior to the VVM ventilation associated based resuscitation in pediatric cardiac arrest. So I think the take-home message from this is that as long when you're in the outside of the hospital treating a patient with a cardiac arrest, I think as long as you can efficiently ventilate the patient, you don't have to rush to do the advanced airway technique, and then prioritize other things such as good chest compressions or delivering the shocks or even the transportation to the hospital. So sorry, this is actually the extra slides, and I'm going to move on to the second article, which is identifying the patient, which talks about the trauma. So identifying the patient with time-sensitive injuries. So as we all know that the trauma is really time-sensitive disease, but identifying which patient have real time critical injury in the field can be very, very challenging. And then decades ago, the concept of this golden hour has been proposed, and then this idea actually led the widespread of the scoop and run approach to EMS with few or no pre-hospital interventions. But many studies have failed to identify an association between increasing pre-hospital time and mortality. And then those previous studies actually had several limitations, which is including the survival bias in the trauma registry data, meaning that those studies only captured those survived long enough to make it to the trauma center, and then those who died on scene or who did not make it to the trauma center were excluded. And while those with non-critical injuries who arrived to the trauma center after long transportation time were included. And then there also is a bias caused by the data set itself that includes the mixture of the critical and non-critical trauma patients. So the aim of the study is to find out, to see if there's any existing trauma triage criteria that can identify patient whose mortality is associated with longer pre-hospital time. So in other words, to find out characteristics of the truly time-sensitive injuries in order to answer to the question, which trauma patient benefit from the rapid transport? So in this study, the authors used the National Trauma Database and included trauma patients age equal to or greater than 16 years and then who are transported from the scene. And their primary outcome was in-hospital mortality. And then they evaluated these existing triage criteria listed here to identify the patient with time-sensitive injuries. So during this study period, little more than 2.5 million patients were eligible for the inclusion. But we all know that not all trauma patient has critical injury. So authors actually plotted the mortality against the pre-hospital time. And then, as you can see, there were higher mortality rate with the patient with the pre-hospital time less than 30 minutes. And after this 30 minutes, the mortality rate actually remained stable or steady. So with this finding, the authors defined pre-hospital time less than 30 minutes as an empiric threshold at which longer pre-hospital time is more likely to be associated with the mortality. So simply, these patients are the really time-sensitive patients. So they looked into these patients whose pre-hospital time was less than 30 minutes. And what they found was the mortality risk increased in patients with total pre-hospital time less than or equal to 30 minutes. But overall, the pre-hospital time was not associated with mortality. And when they performed the interaction testing, what they found was there actually was significant interactions between pre-hospital time and these three characteristics. So a patient with systolic blood pressure less than 90, or a patient with GCS greater than or equal to 8, less than or equal to 8, or patient with non-extremity firearm injury, such as a gunshot wound to the torso, those patients had increased odds of mortality associated with increased total pre-hospital time. But those patients without these criteria, they found no association between mortality and pre-hospital time. So in conclusion, so when you go to the scene of the trauma and see the patients, if you see the patient with a pre-hospital hypotension less than 90, or GCS less than or equal to 8, or non-extremity trauma, non-extremity firearm injury, the patient may have a higher mortality with the increase in pre-hospital time, and then these patients may benefit from the rapid transport to the definitive care.
Good job. So just for the sake of time, we're going to keep moving really quickly. Next up is Dr. Goltz, who we took out of New York to be one of our EMS physicians.
There it goes. Okay. Okay, so the first article that I did was the dispatcher-assisted CPR. So this was an article in Resuscitation recently, and it's looking at basically the impact of dispatcher-associated CPR. It's a big problem in a lot of places, especially in the U.S. There have been a lot of lawsuits where dispatchers haven't really helped people do high-quality CPR and have had bad outcomes. A couple people have been sued. I found out there's only about 6 states that mandate that the dispatchers give detailed instructions on CPR over the phone. So this is just looking at the kind of impact of it. So it was a single center randomized controlled trial. They looked at it in lay people and healthcare professionals in Singapore. They were using a simulated cardiac arrest. Participants were randomized into the dispatch associated, which they did over the phone, or CPR without a dispatcher. So it was 412 participants, and like I said, it included everybody from the general public, doctors, nurses, dentists, medical students, nursing students, EMTs, and CPR instructors. The primary endpoint that they were looking at was CPR compression, depth, rate, no flow time, hand placement, and basically full release during the compressions. The secondary endpoints they were looking at, we're seeing which groups actually benefited from these from dispatch assistance and which other parameters were actually increased, where they increased the CPR quality. So when looking at the primary outcomes, the overall correct compression rate was 34.4% in the dispatch assisted versus 18.1% without the dispatch, which is pretty significant. Everything else, there were no significant differences. In terms of secondary outcomes, which were a little bit more important, there was a correct compression rate in the non-healthcare professionals between 30.2 with the dispatch assistance and 13.3. In healthcare professionals, it was 57.1 versus 34.9, so increased in both of those. The correct compression rate in non-healthcare professionals with valid CPR actually was not clinically significant, or not statistically significant. While the compression rate in non-healthcare providers without valid CPR, the dispatch assistance actually looked like it helped a lot. The interesting thing, healthcare professionals with the dispatch assistance actually had a higher proportion of correct hand placement as well. So what does this mean? It means that dispatch assisted CPR had the biggest impact on the compression rate, especially in these subgroups of the healthcare professionals without valid CPR certification. And those are the non-healthcare professionals without valid CPR certification and in the healthcare professionals. Dispatch-assisted CPR also impacted the correct hand location in the healthcare professionals. And the big thing that we can also take away from this is that CPR quality in healthcare professionals was pretty poor overall, with the appropriate rate only being achieved in 34.9 to 57.1%, and depth 35.7 to 48.8%. So we basically need to do better, even as healthcare professionals. The second article I did was from the Shock ED group. So they're basically known for their ultrasound during CPR and hypotension. This article is actually looking at does point of care ultrasound use impact resuscitation length, rates of intervention, and clinical outcomes during cardiac arrest. And this was from the Shock ED group. So this was a single center, non-randomized control trial asking if patients arriving in the ED in cardiac arrest, does POCUS compared with the usual care affect the length of the resuscitation, frequency of interventions, and the clinical outcome. So there were 223 patients that met the inclusion criteria, and 180 of these had the point of care ultrasound assessment. Like I said, their primary outcomes were looking at the length of resuscitation and the intervention rate, so who we're doing stuff for. The secondary outcomes were looking at rates of ROSC, survival to hospital admission, and survival to hospital discharge. So in terms of the primary outcome, something that we're not very surprised by, but patients in the POCUS group actually received a longer mean duration of resuscitation. And then they kind of subdivided this into with the ultrasound group that had cardiac activity when they did the ultrasound versus without cardiac activity, which you see the times are 27.3 versus 11.51 minutes. And those were longer than without point of care ultrasound. So the patients in the point of care ultrasound group also had a higher intervention rate as compared to without it. In the secondary outcomes, the point of care ultrasound group had a significantly higher rates of ROSC and had a higher survival to hospital admission, but when it came to survival to the hospital discharge, there was no difference. So this basically means that patients with positive cardiac activity on POCUS had longer resuscitation times and more interventions, which was not surprising, while there was no survival benefit. But for me, I will continue to use point of care ultrasound during the cardiac resuscitations. And I mentioned this just doing the CASA protocol, which I've seen a couple of people use. So it's just during these basically you look for cardiac tamponade on the first one, then you do 2 minutes of ACLS, then you look for right heart strain, do 2 more minutes, and then look for cardiac activity to kind of rule out all the causes that you can intervene on.
Fantastic. We're going to keep moving just for time. If you don't know, this is here now, right? So now everybody can buy a Butterfly IQ ultrasound, plug it into their smartphone. You don't need to be a physician, you're a paramedic, an EMT. You can go buy it yourself if your agency doesn't buy it for you. They are cheap, inexpensive. Throw away your stethoscope, right? In 2019, all of our fellows have their own Butterfly IQs, and they have thrown away their stethoscopes. Dr. Arapakai is the Associate Director for the Fellowship for the Physician Response Program, and he's going to have 5 minutes to talk about what everybody keeps asking questions about, heads-up CPR.
Yeah, so heads up, torso up CPR is kind of the big thing on the horizon. It's not quite up and running yet. Just disclosures, I get money from a bunch of different places. I'm a consultant for Claris ultrasound machines, and I'm chair on one of EV Medicine's boards. But I don't think any of that will come into play for this topic right now. And this article came out fairly recently confirming the feasibility, safety of a bundled approach to heads-up CPR. So the thought is that, you know, you have a 911 system where everyone here responds to 911. We get people in cardiac arrest. We have a culturally diverse patient population of old, young, different races, you know, coronary artery disease, diabetes. I think we all know that. We already have bystander CPR in place. I know Dan talked a little bit about dispatcher CPR. They implemented pit crew CPR. They also use a mechanical device. They actually went with the Lucas device, but any mechanical device would work for this method, as well as ITD, which is the impedance threshold, which also kind of increases blood flow. using active compression and decompression. So they actually use that suction cup thing that some of you have seen. And what they showed is that this was through a swine model. If you see on the far left, they induced VFib into these models, and then they kind of did each arm. So active compression, decompression with the ITD, as well as the heads up, torso up, shoulders up, fared the best for cerebral perfusion. If you see that conventional CPR with supine position actually did the worst, and then kind of in between is kind of everything else. So that was actually rather interesting. Not really sure if that's good or bad. This is actually one of their samples where they have the Lucas device. They actually stick a hard case, perhaps a Pelican, underneath a scoop to kind of increase that. They wanted to try and get a reverse Trendelenburg 20 degrees. And they found that by doing this, and it's actually fairly easy to do this if you have everything else in place, they showed that between 2014 and 2017, they almost doubled their resuscitation rate. So these are people get into the hospital with ROSC. Now, whether or not that translates into people walking out of the hospital is yet to be determined. But they found that of the people that they brought to the hospital, it's the same, they have the same spread. So if 10% walked out of the hospital, 10% of these people walked out of the hospital as well. So that's good. Hello? Yeah, so they were looking to do this over a couple years, but they found that so much had changed. So taking my 5 minutes, this is not quite ready for prime time. The most important thing to do right now is to optimize cardiac arrest components that we do know work. Pit crew CPR really does help. Good compressions makes a difference. Although the evidence for mechanical devices aren't really showing clinical outcomes yet, I feel like they help.
That's great. Everybody's talking about this. I mean, I was with Paul Pepe when he presented this at the Eagles Creek meeting, right when the article came out. I can tell you that all these organizations that are making products now for heads-up CPR, it's freaking silly. One, because Paul Pepe, who wrote the article, and RJ, who wrote the article, both said this is not ready to do, right? Number one. Number two, they both said that if you do not do this incorrectly, you actually have worse outcomes. And that's totally true as well. And they show that in their literature. But this is the future, right? These people had significantly better cerebral perfusion pressures when their heads were up, significantly better. But you don't just put the head up, you put it up 20% at a time in multiple stages. If you put the head up all at once, they didn't have better outcome. So you slowly elevate the head while having somebody on a Lucas device with an ITD. Now, I can also tell you there's 8 more studies that are about to come out that have been submitted to journals, and I'll give you a little secret. One of the studies didn't, so one thing that's being experimented on right now is doing this all without the ITD, because that's a long story, but that probably isn't beneficial. But several more studies coming out. This is the future. In a couple of years from now, I bet most of us will be doing this on patients. And this is how we'll be doing CPR. But not ready for prime time. Great job. Last but not least is Dr. Matthew Harris. Matt came all the way from Denver Children's, where Matt runs critical care transport there. Matt's the only PEM EMS paramedic doctor in the entire world, right? Matt called me one night, said, I just got off the plane. I had a kid with a febrile seizure. We talked about in-flight emergencies. I had a kid with a febrile seizure. And Matt was just telling me, so I took care. I did the usual stuff for a kid with febrile seizure. And then I basically sent them home. I said, did you tell that mom that you're the only PEM EMS doc in the entire world and you're a paramedic? And then I kind of left that out.
I've been downgraded. It used to be the entire universe, just the entire world now.
So because Matt flew in with his arms from Denver, we're actually going to give Matt a little bit of time, and then we'll conclude very quickly at the end.
Got it.
And by the way, for those of you who stayed with us till the end, we have T-shirts. I'm just going to say this now. We got a T-shirt box. We have a T-shirt box, different sizes, MD1 program, all this kind of cool stuff on the back. Autumn has it. Raise your hand. So Autumn does everything for me. If you've been texting with me for the last 3 hours, you've been texting with Autumn. So I hope she said good stuff to you back. And if you want to get a hold of me, She probably has my phone, md1admin@md1program.org. And she'll answer back. All yours.
Cool. So this is actually going to be a little bit of a different format than the prior speakers, and actually it's a nice way to sort of sum up a number of the articles that have been touched upon today. You've heard from numerous speakers today that trauma is one of the most common causes for EMS activation. It is the number 1 cause of death in children. So we're going to talk about, and there's a good spectrum of people in the room, what we did with trauma in the past, what we're doing today, and thematically with what we're saying here this evening, what we're doing in the future. And the caveat being that the future, not to sound totally corny, is somewhat happening now here with the MD1 program. I don't have any conflicts, but I'm looking. If any of you guys don't know who this is, can anyone raise their hand and say who this is? Right, so it should be all of you. This is Kendrick Castillo. A week and a half ago, we had yet another school shooting around the corner from where I live in Denver. And not the jock in the room, not the most popular kid in school. On the mechanics team and robotics team, step up, tackle the shooter, and got shot 3 times and lost his life. So I just wanted to recognize them. These are pictures from the shooting. The STEM school is a K through 12 school. The entire school is the size of a football field. So just in terms of thinking of the amount of death and destruction that could have happened if he didn't step up is quite impressive. I'm going to buzz through some of these things. So we're going to start off with a case, and this case is going to guide us all the way through. This is an 11-year-old male, is a restrained passenger in a head-on MBC. There's significant damage to the car, airbags are deployed, and the driver was killed at the scene. Fire services are on their way, extrication is underway, and you're asking yourself as the responding paramedic, what are your priorities? Have any Monarch medics in the room been at this job back in the day? So I was not on this job, my co-fellow Ron was. So the patient you find is alert, he's cut up, his heart rate's 140, he's 11 years old, his systolic's 90, he's pretty tachypnic at 34, he's a little bit hypoxic. You're starting to build your differential of what's going on and what you need to do in the next few minutes as you begin and plan your transport and your treatment options. So long ago, when some of folks in the room weren't born and some of the folks in the room were already having kids, firefighters and police departments would argue about who's going to cut the person out of the car. You'd have 15 people battling their way in, all sorts of funny firefighter devices to cut roofs off cars, doors off cars, and sneaking in the back would be one very unlucky, typically smallest EMT or paramedic holding cervical spine immobilization in the field. And during this battle, this epic battle of what was happening on the scene, we deployed only the latest devices available at the time, called the Kensington extrication device. For those of you who haven't seen this, it is a medieval torture device. And at the time is what we did to fully immobilize patients so that we could twist and turn them onto a backboard and take them out of the car. So for the 5-year-olds in the room, this would be, someone would be sitting behind the car, behind the patient, cervical spine mobilization in place. We would put on the collar without moving their neck. We would slide them forward, maintaining full immobilization, slide this kid back on, pick it up, pull it on, it's stuck on their belt, tie it around them, and then to best show this, you sort of did this to get them onto the backboard and take them out. This was our inline mobilization of the time. I'm sure we can find this in some of the Southern volunteer groups in New Jersey. So the patient's out of the car, they're on the long spine board. This is the standard of care 5 years ago. BLS, it's a traumatically injured patient, 15 liters of oxygen. You can't hurt somebody with oxygen, just ask Dr. Merlin. ALS arrives on scene, they do their detailed physical exam. He's a little bit more tacky, a little bit more hypotensive. He has a seatbelt sign. His lungs are clear as best you can tell. And you're going, gosh, this kid's really pretty injured. He's a pretty bad cut on his arm, so I'm gonna put a whole bunch of gauze on there because that can't possibly hurt somebody, putting a bunch of absorbent material into an actively bleeding site. Paramedics put on the EKG, 2 large bores of IVs are placed. We push in, right? BLS, squeeze the bag, 2 liters of fluid, normal saline, right? Only normal saline. Normal saline saves lives, right, Dr. Merlin? Morphine is deferred because his blood pressure is soft. It's not safe to give narcotics in trauma. And the patient is transported to the closest adult level 1 trauma center. There, he's seen by a general emergency medicine physician. He looks okay, a little bit better. He's moaning in pain because he didn't get any morphine. Then he becomes acutely hypotensive while he's in the CAT scanner. The physician performs a FAST. FAST is looking for a free fluid where it shouldn't be. And the child arrests on the table despite resuscitative efforts and succumbs to his injuries. So we'll kind of buzz through this. Trauma is the #1 cause of death in children. Motor vehicle accidents account for about 50% of trauma in kids. And every year, 50,000 children in the US alone get permanent disabilities as a result of trauma. Part and parcel to all this is understanding what shock is. Shock in children is different than shock in adults. Kids really, this is cliche, kids do really, really, really well until they don't. And frankly, it's not that often that we see someone who don't. But when you do, you need to recognize sort of what to do. I'm going to skip through I'll make these slides available to you guys for signs of trauma. This is just a graphic representation of how adults kind of slowly tank their way down, and kids really do just fine because of their compensatory ability to generate a good cardiac output. So that same patient today, all right, happened outside in Lyons Avenue. An application of a cervical collar is put on. We considered restrictive spinal mobilization, maybe because of the mechanism we decided to go with it, maybe we don't. But we're more primed to recognize those signs of shock. And we're going to consider pain management, what kind of fluids are we going to give, and where should they go today. So just quick and interesting, this is obviously, as we see more and more school shootings, as we see what happened in Las Vegas, the use of tourniquets. So EMTs and medics in the room, how many were working when we didn't have tourniquets on the ambulance? Wasn't that long ago, everyone should raise their hands, right? So tourniquets, which have been around in the military population for 100 years, are relatively new in most EMS systems. This is an interesting descriptive analysis of tourniquet use after the Boston Marathon. Boston EMS was staged throughout different parts of the marathon setting, and obviously after the bombs went off, there were 98 documented cases of tourniquet use, controlled hemorrhage in 91% of cases, but it took on average, pre-hospital application took 15 minutes to put them on. So think about these people who had life-threatening femoral artery injuries. You can exsanguinate in how long, emergency medicine residents? Right. So 15 minutes isn't going to do anything. Sorry, we'll move on. What's really actually interesting is that 27, this is not an EMS study, but 27 non-medically trained people applied tourniquets in the field successfully. And just an interesting thing to show from like a public health perspective. We're going to kind of buzz past this. So our patient is immobilized on a cervical collar. We considered restricted mobilization. Hemorrhage control has been obtained by placing a single gloved hand over the bleeding site. IV access has been contained, and we're making a notification to the receiving hospital. But what about that pain control we spoke about before? So this is a couple studies that looked at the use of fentanyl, both via the intranasal route and the intravenous route, as well as a study on the bottom, which actually looked at both intranasal and intranasal fentanyl and intranasal ketamine for pain management in trauma patients. And the long and the short of it is that none of these patients had clinically significant reductions in their blood pressure, while overwhelmingly they had significant reductions in their pain scores. So we're recognizing now that traumatically injured patients who are hurt and painful, and we know that pain itself is a complex enzyme-mediated process that can actually worsen hypertension, so treating their pain may actually be helping you in preventing worsening tension. For the paramedics in the room who haven't seen this before, this is the only way you should be giving fluids to a hypotensive child, whether it's because of sepsis or because of hemorrhagic shock, anaphylaxis, etc. This is the push-pull method. This is a 3-way stopcock attached to a liter bag or a 500 ml bag. You draw up how many mLs per kilo you want in a 60 cc syringe, and you bolus, bolus, bolus. This is faster than a rapid infuser in most cases and easier to set up, and you don't have a rapid infuser in the field. So mortality, this is my new baby. Children's one. So what happens to these patients on the way to the hospital? Is it based on the type of trauma, where they go, right? So do you take them to the closest level 1 trauma center, or do you say, you know what, 20 minutes further is a pediatric level 1 trauma center, right? Pediatric surgeons, pediatric anesthesiologists, pediatric critical care docs, and doesn't actually make a difference, right? If they're 11 years old, can't they really be taken care of adequately by an adult practitioner? And I don't just say in the emergency room, but an adult team of practitioners who are going to care for this child prior to transfer and the secondary transfer matter. So currently, there are recommendations in most states to defer to a pediatric trauma center, but it's left at the discretion of the paramedic on scene, or the highest level medical care on scene. So this is a study that looked at 175,000 kids traumatically injured under the age of 18, and looked to see if there's an association between where they went, which were pediatric trauma centers, both or adult-only trauma centers, whatever that means, and they risk stratified that by young kids, school-age kids, and adolescents. So sort of interesting. And all of these met statistical significance. I didn't put the p-values on, forgive me. Mortality was 2.3%. Now mortality for pediatric out-of-hospital injuries roughly in the US is somewhere around 1%. But for kids who went with similar ISS scores to an adult trauma center, the mortality was 2.3% versus 1.8% at mixed trauma centers and 0.5%, 0.6% at pediatric trauma centers. And for all comers, the odds ratio of dying was 1.57 at the adult center versus 1.45. That means that you were almost 50% more likely to die as an injured child in an adult trauma center or a mixed trauma center as compared to a pediatric trauma center. And this actually held true at all levels of injury. I'm going to buzz through this. So you get the patient to, sorry, CHCO is Children's Hospital Colorado. You get the patient to the Children's Hospital. Right now we're giving them, 2 liters per minute for nasal cannula just to support them. They have 2 large bore IVs. He got 20 per kilo of fluid in the field because that's the current standard of recommendation. And the heart rate's a little bit better. He looks a little bit better. The fentanyl's on board. He remains somewhat arousable but tachycardic. And you have a whole team of people who work their entire lives just to take care of this particularly ill and sick kid. I'm just going to let you know that when you look at patients at pediatric trauma centers where they have a notification versus when they don't, so when they have survival rates based on a level 1 trauma or a red alert trauma, whatever your highest level is, that first of all, surprisingly, almost 5% of all pediatric traumas will not only activate, but justify an activation of a level 1 trauma. That means you're stopping the OR, you're getting a massive transfusion protocol initiated, excuse me, and almost 50% of those will go to the operating room. There's very little operative trauma in pediatrics, but 50% of kids who meet criteria for a level stat 1 notification, which you're making, will go to the operating room for exploratory lab or an intervention. So this patient's seen again in the ER, they get their ultrasound, the patient hasn't crumped, they go to the OR and they get cared for. What kind of care are they getting now in the ER and how does this translate to what we're starting to do here at the MD1 program and going forward? And what defines a massive transfusion protocol? Because as you heard Dr. Merlin mention a couple of hours ago now, we on the MD1 trucks carry 2 units of low titer blood, which we'll speak about, and does that sort of amount to a massive transfusion protocol? And certainly for in kids that would. So kids who need more than 50% of their blood volume replaced in the first 48 hours are what really defines a massive transfusion protocol. To give you some perspective, most teenage kids or a larger kid will get 75 to 80 mLs per kilo. An 11-year-old is about 32 kilos. That's 2.4 liters of blood in the first 48 hours. That's about a large soda can. I don't know why Shasta is still popular. It tastes gross. So this is actually really important if we go into the next quick topic of whole blood. Certainly in pediatrics, and the reality is, having reviewed the adult literature as well, we know that saline, lactated ringers, isotonic fluids worsen coagulopathy. There are lots of thromboelastographic studies that show that people who get lots of fluids in the pre-hospital setting, and they show this, by the way, we reviewed this article a couple of years ago, that when TEG samples were taken in the field, sort of like at the time of injury or pretty close to the time of injury, and then repeated in the hospital for adult patients, that the TEG was worse in patients who got high volumes of isotonic fluids. So as you consider what prior speakers have talked about giving higher volumes of what you really need, plasma up front in higher concentrations, the question is there a role for EMS to do this? And again, you saw part of the study before. This is sort of interesting. I'm going to come back to this second. This was a study that looked at damage control resuscitation. This looked in, I forget, it was like pigs or some other animal that you can't eat. So they injured patients at the first arrow. They waited 20 minutes. They looked at they waited until their maps got down to 20 to 24. And then the risk groups were stratified into giving crystal, whole blood second, and then it was a switch over type of study. And what's sort of interesting about this is that patients who got whole blood first, not shockingly, had less coagulopathy, required less blood products in the first 24 hours, et cetera. Patients who had got crystalloids had worsening coagulopathies or the opposite. But patients who got crystalloid first and then got whole blood would more quickly correct their coagulopathy afterwards. So if we haven't quite screwed them up by giving them saline in the field, replacing them with whole blood products early on likely reduces their coagulopathy going forward. This is the only good study that everyone in the room needs to know about right now about TXA in the field. This is from 2017, Mark. 2016, 2017, this is the PEDTRAC study. Most pediatric TXA data comes out of the military arena, and basically showed, when all, again, small study, 66 kids, but basically showed that the odds ratio was reduced to 0.27. Now, there's a lot of confounders here about the different types of blood products they got. So how did this kid do? So before he died, because his pain wasn't controlled, he got a lot of fluids, he went to a CAT scan, he wasn't at a pediatric trauma center, died on the table. In the modern day, MTP was initiated, he went to the OR, he got packing done, he went to the PICU, and he was transferred, he made a full recovery. But most importantly, where are we going? If anyone Googles like ambulances of the future and Google, this is the first thing that comes up. I think this would be great. If you Google paramedics of the future, this sort of comes up as well. You know, this is how I view all you guys in the field. This is, if you guys haven't seen, this is MD8. This is a future part of the program. So getting back to our patients and going forward. And, you know, when I give this presentation in Colorado, I build the last 5 minutes of this conversation is, this is what's going to happen at some points in the future. And again, without sounding cliche, this is sort of what we're doing here and now in some respects in pediatrics, in the pre-hospital setting. You guys should be aware that a lot of what we're going to talk about in the next 4 or 5 minutes is something called the 2050 Agenda for EMS. And this is basically what's set forward as the expectation of what EMS will be for the next like 20 or 30 years. At that time, the fellowship will have 25 fellows per year, submarines, aeronautical stuff. Okay, so if you think EMS physicians responding to your house and doing bedside sono to determine your problem is impressive, you know, there's already some trials around, and we kind of alluded to this before, about pre-hospital ultrasound in the field and how it's going to work. This was one study that looked at 104 adult patients, 84 FAST exams were performed, 20 aortic aneurysm exams were performed. And really what they found is that there was really good inter-reader reliability in looking at the images between the paramedics and the, it's probably my mom, between the paramedics and the physicians, which means that this is like a feasibility study, right? But more importantly is how this is going to build into what eventually will be the sort of telemedicine component, of EMS. This is just another study that shows looking at things like yes, no questions, right? POCUS questions. Is there a pneumothorax? Is there a tamponade? Is there something I can do something about in the field, or am I just playing with an expensive toy? And this is just another interesting feasibility study. So this is where, if you're still practicing paramedicine or pre-hospital EMS medicine in a couple of years, this is where we're going to be, right? This is the EMS agenda for 2050. Monarch has a really cool, if you guys get down and see it, Monarch has a really cool simulation ambulance. That's what every ambulance is going to look like going forward. Cameras in multiple parts of the ambulance. In addition to being able to send your EKG, telemetry is going to be streaming live to the center you're going to. Your ultrasound is going to be reviewed by a traumatologist waiting at the trauma center to decide, do I really need to prep an OR or get ready? So the physiologic parameters we have now are going to be sort of live streamed to physicians waiting for you to be there. And for the physicians here, you're going to be sitting in a box. Like, this is part of our future as emergency medicine physicians. We will, at some point, our base station is going to be a series of monitors, and this isn't that far off. Also, for the paramedics in the room who've ever been frustrated, like, going, gosh, I don't know if this is what this guy's EKG looked like the last time he had his chest pain. You know, in the state of Colorado, there's a universal electronic medical record, which is now hooked up to the universal electronic medical record mandated by the state. So all hospitals and paramedics can see each other's charts. So right now, all hospitals can see everything, and Denver Health, which is the large municipal agency, can now see all EKGs within the metropolitan areas. They can compare to prior. What an odd idea. And so your ambulance is going to be built to do this. And there will be centers where we sit and really review this. This is sort of part of the future. A couple quick other things to wrap up. So what's going to happen to that same 11-year-old restrained male passenger on a high-speed NBC where the driver was killed? ALS is going to get unseen, or BLS is going to get unseen. They're going to apply their telemetry, and everyone in this trauma activation is going to be aware. The local trauma center is going to know this is happening before you make the phone call. ALS is going to do a fast. They're going to see clinical signs of shock. They're going to see radiographic evidence of fluids. They're going to say, I'm not giving this person normal saline. I'm going to give them low titer whole blood, TXA, as I get them in and out to the hospital. Interestingly enough, and for the folks in the room who have read sort of the military literature, so TXA, which was sort of new to the ground units when I was an EMS fellow here, and which we kind of gave, and we're like, oh, it's so cool, we gave TXA. we're kind of behind the times. CXA has been given in the civilian population in Israel for about 20 years, and they've described their experience, which has been overwhelmingly positive. And for the skeptics in the room, no one's had a large PE, MI, stroke, et cetera, as a result. So places are already doing this, and these are not pediatric studies, but just all things in pediatrics come second. And this is a similar review to what was presented earlier about out of Pittsburgh, a pre-hospital blood transfusion protocol. Now, this is a HEMS-based unit, a helicopter-based unit. Some were IHOPs, 8 were from the scene, and they basically showed the feasibility of providing whole blood transfusions in the field. I'm going to end off with 2 last things that are really sort of cool we learned about at NAEMSP, the National Association of EMS Physicians. So if you are in, if you're in Manhattan and you have a sick kid and you are not quite sure the best place to go, Manhattan, you sort of spin in any direction, you hit a hospital. This is an app which you guys can actually download now. It's free. I have no vested financial interest, which is unfortunate. This is called the PD tree. And the app is actually being modified, but where it started is this concept in Baltimore where they said, well, what are the 20 most common complaints that really require emergent care in pediatrics? Sepsis, anaphylaxis, trauma, et cetera. So you can go into this app and you can say, I have a 2-year-old, his heart rate's this, the blood pressure is this. They're gonna say, do you screen positive for sepsis? Yes. It hooks up to your Waze or to your electronic GPS and it says, hey, there are 3 hospitals within 2 miles of you. One of those hospitals has a pediatric trauma center with an ICU, with a PICU. So the app actually knows about the hospitals and their capabilities. And the next step actually, especially in states like Colorado where everybody's really forced to be in line with each other, is how many beds are available in the ER? Are there PICU beds available to help reduce secondary transfers? So this is the PD tree. But again, to kind of wrap up here, it's our patient in the future will get good care at the scene, care initiated on the route to the hospital, will know where to go. And that was a 70-slide thing in 20 minutes, so you owe me big time. and I have to ask Dr. Merlin, you know, if you remember the show Emergency Medicine, just remember that in the show for MD1, it was George Clooney who played the pediatric emergency medicine doc, so pick somebody good. Okay.
So we're going to take a solid 5 minutes and let you guys ask questions. Barbara President is here, who is chair of the state ALS committee. So, all right, guys, your turn. So as a first question, but I'm going to give you a chance to disagree with anything we said. It's okay. We're EMS docs, so we have tough skins. Sim Shane, CEO, Paraflight EMS. Go ahead.
First of all, amazing lecture. Thank you so much. Have you changed your thought process?
Yeah, you know, I mean, my thoughts are, I wish it was less expensive. I think that with heads-up CPR, we're going to have to find money for some of this because I do believe this is the future, although it's not ready for prime time. I certainly think, as you know, that we all do terrible CPR in the back of moving ambulances. And I think that we all get tired. But I do think there are 6 studies which have compared mechanical CPR versus manual CPR. And if you don't know this, all 6 studies, manual CPR wins. Let me say that again. In all 6 studies, manual CPR on multiple endpoints beats mechanical. And the answer of why that is, and the fellows have heard me say this ad nauseum, is because it takes the average of 36 seconds to put the device on people. That was the biggest study that was done. The only number you have to remember is for every 5 seconds you interrupt compression, survival goes down by 17%, right? Circulation study a few years ago. Every 5 seconds you interrupt compressions, survival goes down by 17%. If it takes you 36 seconds to put the device on, you're killing the patient, unless you go and practice